Friday भी आ जाते हैं पेट्रोल पे जो बाइक से
Aman, I'm waiting for your reply. Aman, can we go live?
Recording in progress.
Right, thank you.
Friday भी आ जाते हैं
So,
पेट्रोल पे जो बाइक से
Pallavi, you want to get rolling?
Yes, the
Aman, I'm
recording is
waiting for your
starting. So,
reply.
good evening,
Aman, can we
everyone.
go
Good
live?
evening to all the stall
Recording in
online
progress.
Right,
experts
thank
from
you.
Friday भी आ
ISAR
जाते हैं
who are
So,
present
पेट्रोल
on this
पे
call.
जो
This is Pallavi More, the head of marketing, speaking on behalf of the entire staff of Universal Nutrascience, popularly known as UNS, and also the group that represents and markets and promotes CoQ in India, the first coenzyme Q10 brand in the market, and also the only brand that provides natural source that provides best IVF outcomes to you as well as to your patients. So, Dr. UNS is an organization which holds the history of almost 3 decades in India. And we are also the largest exporter of coenzyme Q10 across the globe.
Yes, doctor.
Our makers are the original owners of Universal Medicare, which were also part of Sanofi. And now we are an independent organization, more open organization, and of course, following all the ethical guidelines that we need to follow in the nutraceutical and the pharmaceutical space. So, here from UNS, I want to wish a very good evening to everyone and to all the faculty members, to all the chair who are present on this call today. And we shall take this journey of science ahead together. UNS is known amongst the doctors' fraternity to promote their brands ethically and scientifically, and which is why we tie the hands with ISAR to promote and steer the science of the IVF forward. Innovative topics, innovative subjects are brought to the limelight under the leadership of Dr. Anu Agarwal and Dr. Bessie Lewis, and in their association. We love to host you every evening, once in a month, and we would continue to do so. So, with this, I think we should start our today's discussion. I will hand over the baton now to Dr. Manish Garg, who is our medical director at UNS. Dr. Manish, over to you. Thank you so much.
Sure. Thanks a lot, Pallavi. So what I'll do is I'll just take a minute to introduce our national conveners who will then take it over from there. So as Pallavi, our marketing head, has highlighted that this is the fifth in the series of our Catalyst series, the ISAR UNS Fertility Catalyst series. And we are having this meeting every month. This meeting is happening. This is the fifth in series. So we are literally blessed to have literally all the stars who have descended for this meeting. So we are literally blessed to have all these faculty out here, senior faculty is out here. Dr. Anu Agarwal and Dr. Fessie Lewis are the facilitators for this ISAR Fertility Catalyst series. Dr. Anu Agarwal hails from Varanasi, as we all know. She is the director of Vansh Fertility and Test Tube Baby Center as well as Ayushman Hospital, and she has several achievements and credits and publications to her credit. We are also blessed to have Dr. Fessie Lewis, who helps us. He is the national convener for this series, ISAR series. He is a professor and HOD at Department of Reproductive Medicines and Surgery at Amrita Institute of Medical Science, Cochin. And again, you see he has several awards and several publications and several posts which he holds to his credit. So with this brief intro, I'll pass it on to Dr. Anu Agarwal and Fessie Lewis, sir, for further proceedings. Ma'am, over to you. Sir, over to you.
Yeah. Very good evening to all of you. It's a real pleasure to have you all here today. And your all presence marks a cornerstone for this webinar success. And along with my co-convener, Dr. Fessie Lewis, I welcome you all in the sixth series of ISAR Fertility Catalyst series, which is a brainchild of our ISAR president, Dr. Amit Patki, sir. I think he hasn't joined yet. Sir is here?
No, he's not yet.
He's joining. He's joining. Just I called him. Yeah.
So today we are going to discuss very important topics. And always we are puzzled about which progesterone to start, when to start, which route, and about the triggering, which trigger to be used when. So we'll have answer of these questions. And Dr. Seema is coming with the fantastic panel discussion.
Ma'am, sir has joined in.
Sir has joined.
Yeah, Dr. Amit Patki sir has joined in.
Welcome, Dr.
Hi,
Hi, sir.
good evening, Dr. Anu.
Good evening, sir.
It looks like it's very cold where you are.
Not very cold, sir. We are wearing cotton coats.
How are you? All good?
Yes, sir. All good, sir.
So you can start whenever you want. I'm there on the stage.
Started, sir. We have started.
Started, sir.
Introducing.
Sir, I was saying it's a ISAR Fertility Catalyst series is your brainchild. And thank you for this wonderful opportunity, sir. Sir, a few pearls of wisdom from you, sir. Over to you, sir.
So, very good evening to you all. And at the onset, I want to congratulate Dr. Anu and Dr. Fesi for having conducted such an excellent catalyst series. And every time the numbers are increasing and the response that we are getting is overwhelming. So congratulations to you all both. And frankly, it is not my brainchild, it is your child, which I've approved and you all have seen it grow and how. So thank you once again. And I'm sure it will benefit all viewers and listeners for the excellent speakers that are there on the webinar and the excellent moderators and panelists. So I look forward to a very educative evening, and I'm sure we'll all come back with very good take-home messages. So thank you once again, and I would request you all to take the proceedings ahead.
Thank you, sir, once again for coming and blessing us and guiding us in this webinar series. I think as your idea, we are focusing on one topic each time. So that will be really useful for those who are interested and those who just want to know about that topic. And also our energetic secretary, Dr. Asha Bakshi, I think she could not join. Is she there?
Dr. Fesi, she won't be joining today. She has some urgent work to do.
Okay. So we will call our chief guest and guest of honor. Prakash Trivedi sir also supposed to join, but we will introduce him once he joins. So we have our guest of honor, none other than Dr. Kanti Ben sir. She doesn't need any introduction to any infertility specialist. I think she's the director of Safal Fertility Foundation, Ahmedabad, pioneer in the field of assisted reproduction at Gujarat and all over India, pioneer in artificial intelligence, virtual reality, and haptics in ART, awarded RCOG Distinguished Service Medal in 2020. Specialization is the management of infertile couple, PCO, endometriosis, and women healthcare. She was the endometriosis committee chairperson of OXY. And 12 books published in PCOS, endometriosis, infertility, and ART, and are used by the references by medical students all over India, and guide to PG students and visiting faculty at Gujarat University. Over to you, madam, to give your pearls of wisdom, madam.
Thank you so much, Fesi, for reading each and every line of my CV. It was not necessary, though. Thank you so much. Dear Dr. Amit Patki, congratulations, and I'm really clean ball by the programs and events that you have. What wonderful sessions, and very educative and academic, and at the same time novel ones, not the same old. Like, this is the catalyst, and what I've seen about this catalyst series is it is really acting as a catalyst in between the faculty and the delegates, and it's really encouraging for all of us to learn more and more. And you are one of the best president of ISAR, and you're not at all biased to give a chance to each and everybody. Very fair. I'm not really just
Thank you so much, Kanti. You have made my day.
Thank you. And Dr. Anu, she's my, I don't know what to tell. She's my student, my friend, my child. And she really needs appreciation. She's doing so well. And I can very proudly say that she's number one in Varanasi. And I think so nearly more than half of Uttar Pradesh are doing such good work, giving so many babies. And together with Anu, we have even given baby to Kashi Vishwanath priest's son. Yes, Anu? Yeah. And then also have such dear friends, Dr. Rajesh Koradia, who is going to speak on progesterone, and he's really a good teacher as well. We have started that. He has started Verdict, and I feel so proud because now the people around India have started recognizing me as a teacher all over and say, Madam, we are learning from you in Verdict. Thank you, Rajesh, for that Verdict. Yeah. And Dr. Prakash, he is my mentor, very good endoscopic surgeon. I think he doesn't remember that I got trained in endoscopy under him in Jeslock Hospital. And that time I was flabbergasted by the, he used to say, I have done this fibroid and that. I was not too much interested in endoscopy, but I thought my ERT will be incomplete if I don't know. And he used to tell I have operated so many fibroids and all that. I salute you, Dr. Prakash. So now regarding the topics that Anu and Pesi have selected under the guidance of Dr. Amit Patki, of course, progesterone is such a, I think we don't know anything about progesterone sometimes. We're just giving whatever we want and we're getting pregnancies, and sometimes we're not getting pregnancies. How to give orally, vaginally, injections. So when I started my IVF and all, I never knew that we'll have to give injections. We only used to give the micronized vaginal progesterone, and we used to get good number of pregnancies positive. But now the newer generation says we need to test for the progesterone. How much is it? That use estrogen. How much is it? And then we have to give injection progesterone. I didn't believe it, but then recently I saw one, one speaker from UK, and he told in his lecture that it's not that we don't get pregnancies. We do get pregnancies with only vaginal progesterone, but the incidence of miscarriages is much more if we don't supplement with this injection. So I also had a doubt, how much of injection do we, what milligrams, 50, 100, 200, how much is it? But then actually some of my friends in India, they said, give 100 every alternate day. I didn't like that giving alternate day. So when I heard this lecture, he said 50 milligrams injection every day. So now I am giving that to my patients so that they do not, even if they conceive, they should not have any miscarriage. This is a bit what I wanted to tell about progesterone. And then we have another very interesting talk on the triggering of the ovulation. Now again, triggering, in our days, we did not have any agonist trigger. And so that was it was not good. We have treated many cases of OHSS, and this now the IVF specialists are blessed because they do not have that problem at all because of the agonist trigger. Now a new thing I have learned that generally people give agonist trigger and also HCG, from which we get better results. So there's a lot of improvement. There are a lot of newer horizons in learning of IVF and creating more babies for our childless couples. And I'm sure Ashish Kale and the other speaker, Seema Pandey, sorry Seema, are going to really talk much more than whatever little I had to. And I wish all the best to all of you. And once again, Dr. Amit, thank you so much. Ashish is also one of my very favorite, clinician, friend, etc. All of you, best of luck. Dr. Prakash, I spoke first because I think there was a little bit delay. Thank you so much for being so patient, and all the best.
Welcome, sir. Dr. Prakash, sir. Good evening, sir. Dr. Fesi, please invite Dr. Prakash.
any of our gynecologists or infertility specialists or laparoscopy surgeons in India. But as a formality, I will introduce Professor Prakash Trivedi, sir.
Firstly, I would like to interrupt.
Okay.
As such, we waited for a long time. No need of introducing me. Because ISAR, IG, Foxy, all of you are all part and soul of me. So don't waste time on introduction.
Please give your advice, sir, pearls of wisdom.
Yeah. So I'll just be very brief, most important. Obviously, we congratulate Amit Patki, the outstanding president, and he does work very meticulously. I am particularly impressed seeing Rajesh Koradia, because Rajesh Koradia 25 years back used to come to pick up some endoscopy from me, which he picked up very well. And for last 6 years, I am picking IVF from Rajesh Koradia. And Percy, of course, a excellent person. And our ever young Ashish Kale, in last 5 years, I realized he is a very good person and a good friend. And our friend from Ahmedabad, she is very encouraging. So without disturbing in coming in the way of the importance of the talk, we straight away move with the talk and we all start learning. Thank you.
Thank you, sir. I think we are really privileged to have you here as a chief guest, and we like to get your blessings from you. I think over to Dr. Anu for inviting, because only there is a slight change in the order. First, Dr. Ashish will be speaking. Over to Dr. Anu.
Yeah. Thank you, Dr. Fessy. So our first talk is Art of Triggering in Own Ovulation Induction, which, when, and why. So it's a very interesting topic. And for this, I would like to invite chairpersons for this session, Dr. Anuradha Khar. Actually, we are not changing our chairpersons. Will you show the CV of Dr. Anuradha Khar, please?
Sure, ma'am. Just a minute.
आवाज आपको पढ़ा है तो यहाँ से आपको
Just a minute, ma'am. Sure.
No, before that. Yes, chairperson slides. Yes.
Yeah, she's a very good friend of mine. She's MD. She has a diploma in reproductive medicine, Germany. She's director of Nurture Fertility Center, Bangalore, and she's currently practicing infertility and endoscopy at Bangalore. She's honorary treasurer, Karnataka chapter of ISAR 23-25, and she's member managing committee of ISAR 24-26. Our next chairperson, welcome Dr. Anuradha. Next chairperson is Dr. Shweta Kaul. Dr. Shweta, she has won gold medal and for all-rounder best student at MBBS. That's great. And she's first board certified reproductive medicine specialist, FNB Reproductive Medicine of Madhya Pradesh. And she has been conferred with Dronacharya Award by ISAR for services at MP region at ISAR Bhopal 23. Welcome, Dr. Shweta.
Thank you.
And our next chairperson, she's Dr. Ella Gupta, very good friend of mine. She's director and senior consultant, reproductive medicine, Fertility IVF and Fertility Clinics, Delhi. She is treasurer and executive member of Fertility Preservation Society, India. And she's teaching faculty, IVS fellows, MIT University, co-convener of IFS Patient Resource Committee. And she's past secretary, IFS Haryana chapter, ex-head reproductive medicine unit, Artemis Hospital, Gurgaon. Welcome, Dr. Ella.
Thank you, Anu. Thank you so much for inviting me for this CME online webinar. And it's nice to see all the senior doctors and my friends here. And all the best for this CME. Hope we'll have a very informative session.
Thank you. I request the chairpersons to introduce our speaker, Dr. Ashish Kale.
Is Dr. Anuradha there?
Dr.
Can you hear?
Anu, can you hear me?
Yeah,
Yes,
you're
yes,
audible.
Yeah. Shall I go ahead?
yes, yes.
Okay, it is my proud pleasure to introduce a colleague and a very good friend of mine, Dr. Ashish Kale. He actually needs no introduction, but just to fill the formality, he is Family Welfare Committee Chairperson, Foxy, Treasurer ISAR, Executive Member IAG, Secretary Pune OBG Society, Founder Librarian Maharashtra Chapter IAG, Executive Member Maharashtra Chapter ISAR, Executive Member National ISAR, Vice President Pino OBG, and recipient of number of awards from Legends of Gynecology, Foxy Badlav, IGAAGL Skill Excellence Award, ISAR Youth Icon, B for 3 Amox Award, UP Star, ISAR Young Talent Award, Champions of ISAR, Kamni Rao Oration, Young Achiever Award, IMA, Foxy Future Award, Young Achiever Award, and he's a peer reviewer Jogi and member of ESHRE and many organizations. And most importantly, he has written 34 chapters in books and 10 original research papers in Index Journal and more than 500 talks at national and international congresses. We are very happy to have you, Dr. Ashish, with us.
Thank you, everyone. My screen is visible. Let me know. Is it visible?
Yes, sir, visible.
Yeah.
Ashish, little more louder. The sound is less.
Now I'm audible to everyone.
Yes, better.
Yeah, at the outset, I'm really thankful to our President of ISAR, Dr. Amit Patki, Secretary of ISAR, Dr. Asha Bakshi, my friends who are convener, Dr. Fesi and Anu, for inviting me here. Today, I will be talking about one of the important factors. All of us does ovulation induction. All of us use different regime for induction for the ovulation. But what thinks a $1 billion question is to how you trigger it. What is your Ford ratio? What is your follicle output ratio? So that is the $1 billion question. And if I'm talking about what is the good IVF specialist, those who are retrieved at least a 2/3 of the Ford ratio. So that means that whenever you are seeing the follicles, maybe a 10, what is your M2 oocyte retrieval is makes a challenges, and that I am going to talk about. So here is the art. The art comes with your passion. Art comes with what you like. And the art is the science where you just pour your mind and heart and soul and to master it. So that is the where you start your induction. And once you start your induction, one should be understanding why it is important to know the ovulatory trigger. The nature has given its own role. It has plays its role that there is a LH surge, and after the LH surge, there is a M2 oocytes, which is relatively a short half-life, will be going to release, and hence the trigger of ovulation is required for the timing of the intercourse, and when we doing it for the IUI and IVF. For the nature has done its own role. The nature has talked about the different things that we should be knowing about. That every single patient going to ovulate once in that menstrual cycle naturally. So majority of will be having a singleton pregnancy, or if your ovulation is going to have a multiple formation of the eggs, then the chances of the twin pregnancy will be increased. If we know that, so what are the options we have? We do have a recombinant options. We do have a 5,000, 10,000 urinary HCG. We do have a agonist trigger. We do have a dual trigger or double trigger. Then we must understand that when we wanted to trigger the patient, whether that trigger is going to yield me the M2 oocyte. That is the first question. Second question, that M2 oocytes are going to give me a number of pregnancies, a number of formation of the blastocyst, if I am talking about the day 5. And what is the state of the patient, whether the patient comes from the Posidion 3 or 4 groups, or whether they are young patients, they are stimulated for the IUI patients. So the trigger has its own implications as far as the IUI and IVF is considered. But thinking like that, we must understand that nowadays the recombinant and urinary is having the same potential, but the urinary may have changes in their composition. If you are giving a 5,000 as a trigger, you may have a 3,000 units into it, or maybe a little bit more. So thinking that the essentiality of the trigger is the induction of the control ovarian stimulation, because we don't want multiple pregnancies. We don't want the OHSs to happen. So these things needs to be understood. Then there is a need of a LH surge that is important for the ovulation. Thinking that if we really need of a LH surge, the LH is a surrogate marker of the HCG. And that particular LH after luteolysis also, we need to have a luteal phase And my previous speaker will be talking about the luteal phase support, and I will be just pointing it out why the LS surge is required and what is the physiological LS surge is going to have an impact on the luteal phase, and if we are doing with the triggering with the different agents, whether it is going to affect the luteal phase or not. So here is the differences in the trigger. You have a SCG, GnRH agonist, and the final follicular maturation. The surrogate markers is mid-cycle LS surge, and if you can see the GnRH analog, if I'm giving it like a triptylin or maybe any of the formation, it will have its action, but its action is only for 20 hours and it goes down. If you're thinking of the natural LS surge, here I will draw the LS surge is going to get on the 14 hours. 14 hours will be a stagnant, and then it is going to go down, and that's why in some when we talking about stimulated IUI cycles, we know that in luteal phase, that is the ISAR guidelines also tell us that in a stimulation of the IUI cycles where we are thinking of multiple follicles generation, we need to give a luteal phase support. But whether we wanted to extrapolate it, when we give the SCG will have a definitely LS surge, but it is going to get for a little bit longer time. And that's why 1 or 2 days later also, if all of us knows that beautiful paper that luteal phase can be started at just prior to the embryo transfer, it will not going to hamper our pregnancy rate. And that is the good thing about the SCG, but we need to talk about what exactly it will do. The SCG used more than 45 years. It's not something new as a trigger. We know once it has been given, it has a longer duration of action, and it has a bad thing when you are thinking of a more oocyte generations, because the smaller follicles will land up into OHSS, and that will going to liberate more problems for us. Both LH and the SCG binds to the same receptors, and that's why when we are giving the recombinant SCG or the SCG, it just replaces the LH and it causes the LS surge, and we have the ovulation to occur. The induction of the final maturation of the follicles and early luteinizations in the woman, we are going to have the recombinant SCG. When we compare to the urinary, the recombinant is a better because of two things that we definitely certain about the dose. There is no impurities like a urinary proteins in it. So definitely when we are going to trigger the follicles with some kind of the dose, it will be a consistent rather than a variable dose as far as the urinary component is considered. These are the paper where they showed that the recombinant SCG gives a more yield of the M2 sites, higher luteal progesterone, and the better injections tolerance, because it usually comes in a subcutaneous way and the urinary way where we give an intramuscular way. Till what levels of the SCG triggers are the lysing estradiol is the culprit. All of us knows that if the estradiol levels are more, the more is going to get OHSS problems. But mind well, friends, whenever you are talking about the OHSS, nowadays gone are the days where we are thinking of the OHSS as a complications, because we are meticulously monitoring the patients. We monitor the dose according to the calendar of age related to BMI, what is the previous fertility outcome. So we are not giving the higher gonadotropins. We schedule the patients with the dependence upon their age and the BMI. There is no evidence of the difference in the clinical outcome as well as the live birth rate is considered or the ongoing pregnancy rates. As far as the OHSS is considered, it is little bit on a higher side when you are going to give a recombinant SCG as a trigger. So what are the problems with the SCG as a trigger? There is a no FSS surge. If you are thinking the two as a trigger, like a GnRH analog as well as the SCG is only giving to give you a LH. But when you're talking about GnRH analog as a trigger, it gives the FSH surge because it gives a first is a stimulation and then it's down regulation. So first we have the FSH. Some of the patients will have a little bit FSH support also, because why it is needed. If you go back to the paper where they said that if you give the one dose of the gonadotropin at the time of the trigger, the number of M2 oocyte retrieval is higher. So we require that little bit number of the gonadotropins to be given at the time of the trigger also. That can be easily been achieved when you are triggering with the GnRH analog. And secondly, there is a half-life. So when we're talking about the half-life, I'll go a little bit later detail into it. Why we need to have a newer ovulation triggers? So we are always afraid as a IVF consultant that we should not venture into OHSS. And secondly, the main difference is between the LH and SCG is a prolonged half-life. If I am giving the SCG, all of us knows that SCG, once we given as a trigger, there is a called as early OHSS and late OHSS. Early OHSS settle up after a 3 to 4 days. It doesn't come up when you give the trigger, you just do the pickup. The OHS never starts at that time. The OHS starts when after the 4 to 5 days, and that is the early onset. And late onset, if she become pregnant, then again it is a problem. So we don't want that problems to happen, and that's why we switch to the another trigger that is called as a GNH analog. So the take home is like the ART. If at all you wish to have the ART cycles to be given, the risk of OHSS is there. The freeze all strategies for the some of the things. So why not to go with the safe trigger, that is a agonist trigger. And the agonist trigger, when you are talking about the agonist trigger for the final maturation, it's not something new. It has been there for a longer time now. But I will be today talking about what is the when you are going to give a GNH analog with the SCG, because if you wish to go with the phase transfer wherein the luteal phase is going to get affected, so I will be talking on that in a later while. So we know that GNH analog can be given as a trigger because it's safest. It's initially causes the flare and then it is not a long acting. So whenever we are giving the GNH as a trigger, here you can see the SCG increase the LH activity but does not cause the FSH surge. Once you are seeing this is the SCG group, this is a recombinant LH. You can give a recombinant LH as a trigger. It's not like that you cannot give a recombinant LH, but there is a trick of giving a recombinant LH as a trigger. I will be talking that in a few minutes. But if you can compare, these are the three options what we can have. We have a SCG, we have a recombinant LH and GNH analog. If you can take a GNH analog and the FSH, there is a little bit surge in a FSH when you trigger it. The similarly will not happen when you are giving with the recombinant SCG. And that's what I was talking about the last day of the trigger. If you give a gonadotropin, it will be always better to recruit that extra mile or extra oocyte to have. But we definitely know the GNH analog, when you are using in an ANTAC cycle, all of us knows that when we are doing only ANTAC cycle, you can give a GNH analog. This GNH analog replaces the antagonist in that cycle, and that causes the first is a surge, and then you cause LS surge to achieve. So what is the difference when you're giving a GNH antagonist and agonist as a trigger? Usually we talk about 8 to 10 hours. It is better that you give a antag in the morning and the trigger as a GNH analog in the night. Usually that suffices because you need to have that much of the receptors going to get replaced when you are giving a GNH analog. So secondly, GNH agonist at the time of ovulation, it is what I was talking here. You can see this is the FSH control when you are having a FSH. FSH is also going to have a little bit FSH surge and then it will goes down. Similarly, LH will has the surge and LH will go down. More M2 oocyte will be retrieved because of the short LH activity and short FSH activity. You will not have the OHSS as far as the GNH analog trigger is considered. So GNH analog is a better trigger. Yes, it do, but it has its own side effects. It is a more physiological. I do understand it is more physiological because it has a shorter life. It promotes LH receptor formation on the granulosa cells, and that's why your M2 oocyte retrieval is more on the more side. And it has a resumption of the meiotic activity in the later stage. Then coming down to the GNH agonist for the triggering of the final oocyte maturation and the patients wherein you thought of it is a hyperresponder. Hyperresponders, we know that a PCOS or maybe a follicles AFC more than 15, where we thought of having said that more and more follicles are going to get recruited. In those, these are the RCDs started from 2005. The Umaydon himself come with this particular postulate that you can give a GNH agonist as a trigger. And these are now very much safely acceptable as far as the meta-analysis is considered also. Hyperresponder, we definitely go with the agonist trigger. We may thought of freeze-all or we may thought of phase transfer, but there is a problem when we're talking about the phase transfer because there is a luteolysis, because if you are giving a GNH analog, GnRH analog causes a rapid luteolysis, and rapid luteolysis causes a decrease in your progesterone levels. We have the papers for that. So do we need to have a dual trigger here? Then the billion-dollar questions comes, the dual trigger and what is its importance? These are the, when you're talking about agonist as a trigger, we should categorize number of follicles at the day of OPU, whether it is more than 14, 15 to 25, more than 26. These are given in a human reproductive paper in 2013. If you are getting a more M2 oocytes, now with the ART law and everything, I know none of us are there to have such a M2 oocytes to retrieve. But at all, if at all it is going to get, then we have to have a freeze-all strategies for those patients. But if they are going to have a lesser than that and going for the fresh, then definitely a luteal phase support with the SCG 1500 at the time of OPU, and then you can give a progesterone gel. You can have that. The mid luteal LH is 1.5, the post agonist trigger with compared to the LH of 6. What it means to you? The natural, when you're talking about the natural LH surge, and after the surge is what is the LH levels, because LH is again the surrogate markers. If you need to have a LH activity, because it will gives a positive feedback for the progesterone, and the progesterone comes into circulation for your luteal phase support. So mid luteal LH, if it is a lesser against the agonist trigger, definitely a luteal phase has to be given, otherwise they will go into luteal phase deficiency. The LH surge, the optimum LH, what we required is a 15 international units, duration is of 14 to 18 hours. Inadequate response decrease the oocyte yield. So that's why we need a highest peak at the time of the retrieval. And then after we require the progesterone to come in after 12 hours, and the maximum P for rise is 3.5 milligram per ml, the strongest correlation which you can have in the oocyte retrieval. So improving the outcome of GnRH analog trigger, what we usually give is a decapeptyl. We can give a higher dose to 0.2. Usually, when we call the patient after 12 hours, do the LH and P4 assay. Some of them are may not be liking my statement, because too much of blood test. Some of the faculties, they don't like to do it. But when you go and you travel across the world, usually these are the things which you need to talk to the patient why you are giving it. So these are the modalities when you are giving the documentations. These are the protocols what we follow. These are the progesterone, and these are the progesterone what we give. Because some of the time what the Dr. Kanti madam was talking about, vaginal progesterone coming down to the oral progesterone and dydrogesterone, all these things, we need to be rational enough to give it. The trigger should be given at 12 hours at least of the dose of antag. What I usually practice 8 to 10 hours gap between the two. The difference between GnRH agonist is to repeat trigger, whether you wanted to repeat it with the SCG, what I'm going to cover it, which is what is called as a dual trigger or double trigger. The repeat of the same dose after the 12 hours, if the patient is always, if she is a PCOD where you are thinking of empty follicular syndrome, or the peak E2 is not that great. So you can definitely repeat agonist trigger. With the SCG in a donor cycle, these are the different what do you call as groups, study groups, where they said that whenever you are giving the SCG as well as GnRH agonist, number of cycles, they compare number of M2 sites, what they compare. There is a statistical difference, absolutely nothing as far as the M2 oocyte is considered, but it is a safer. But ongoing pregnancy rate, if you are thinking that the clinical and the pregnancy in the both the cycles, there is no difference in the live birth rate. So if we have the molecule which can reduce the risk of OHSS, definitely GnRH analog can be given as a trigger. The risk of mitigations like a letrozole, continuation of antagonist, calcium gluconate, and reduce the dose to the half. Some of them give a micro dose and all that thing. But this is not going to get a remedy when you're talking about the OHSS once it happens. The combination of the trigger, here is the billion-dollar question again comes, in which patients in whom I will add a GnRH analog with your SCG, a small dose. Some of the investigators, they given it simultaneously, and that's why they talked about it as a dual trigger. And otherwise, it gives a SCG later to rescue the luteal phase, what I was talking about, because it causes a rapid luteolysis, and that's why they called it as a double trigger. So here is the funny things which come, the indications of the dual trigger and double trigger. if the previous history, if more than 25% of the immature oocyte has been retrieved, what we call as empty follicular syndrome actually doesn't exist, because if you are not good in your triggering, if you're not knowing about the LH and mechanism of LH, it's your fault rather than talking about the empty follicular syndrome. It is very, very small quantity which is exist in the literature called as this empty follicular syndrome. To prevent OHSS in a PCOS patient, definitely you can give it a small dose of SCG will be helpful for the support of the luteal phase. To get adequate luteal phase support in a PCOS, because this PCOS usually in your practice also, many of people will vouch for me that that the PCOS patient, they consider they have a chemical pregnancies or maybe a biological pregnancies test positive, but the live birth rate is not that great. That's because of the inadequate luteal phase support. And definitely a poor responders is one of the billion-dollar questions in whom I should be liking to give this dual trigger. As I mentioned, if the oocyte retrieval is immature, is more, then definitely you think of the dual trigger or double trigger. The impact on the number of oocytes, mature oocytes are more. Optimize the follicular output ratio, that what I was talked in previously when I started my lecture as a quote, that is the output, follicular output ratio. Fertilization rate, abortion rate, and the embryo transfer cancellation rate has been decreased when you're talking about a dual trigger. Then coming down to the subset of the group where we can use this particular strategy is our favorite group is a poor responder. In fact, we should not be giving a dual trigger for the normal responder because there is no statistical difference as far as the M2 oocyte is considered. But if you are giving in poor responders, definitely a dual trigger will be helpful for those, because all of us knows the single M2 oocyte makes a hell of a difference as far as the live birth rate is considered. If I'm getting a one good quality of the M2 oocyte, I'll be definitely going for the more things of a good blastocyst formation, aneuploid embryos, and take-home baby rate. So these are the protocols what we used and that are been there. The LH, the low retrieval rate, these are known facts. The dual trigger increase the oocyte retrieval rates, and there may be a slight increase in the dose. Normal responders, the dual trigger with the gonadotropin releasing hormone agonist and the SCG improves the live birth rate. In a normal responder, if at all you are giving and where you are thinking that the fort is not good, you can try this. This is a comparative trial of a dual trigger with the SCG. SCG is the control group, wherein SCG with the triptyline has been given. You can see there is a statistical difference in the live birth rate, the abortion rate, and the twin pregnancy rate. So when you are talking about the poor responders or a normal responder where your fort ratio is not good, you can definitely think of the dual trigger or the double trigger. This I was talking about, these are the patients wherein you are really suspicious about, where the group 3 and group 4 are really patients where you need to go that single M2 set makes an important thing as far as the live birth rate is considered. So the which trigger and when, these are the summary of it. The normal responders, usually you can think of IUI cycles or maybe IVF cycles of the SCG. GNH agonist trigger hyper responders, we don't want it to land up into OHSS. You can have GNH agonist for the patients wherein the oncofertility, what we practice in our centers, definitely I switch over to the GNH agonist. Dual trigger or modified luteal phase support. Hypo responders, I will not say hyper, but hypo responders definitely a poor responders. Dual trigger is the take home, because it will support your a little bit extra for that luteal phase. So the fresh embryo transfer versus a frozen, I will not venture into the details after giving the trigger because my talk is related to the trigger. But once you're talking about the trigger in our poor responders, sometimes all of us do a phrase transfers in those patients. Definitely you are thinking of the phrase transfer rather than the frozen, but the success rate remains the same nowadays. We're not having a statistical significance. Trigger in modified natural cycles in the embryo transfer in the ovulatory females. Definitely SCG administered after the endogenous LH rise negatively impact your pregnancy rate. And that's why when you are doing a natural cycle embryo transfer, usually you see to it that when if at all you are giving a SCG just like that, it will hamper your pregnancy rate rather than good beneficial for the patients. So these are the conclusions of it. That's from my side. If there are any questions, I'm happy to take it. Thank you. Thank you for patience here.
Thank you, Ashish, for that wonderful insight of that. I think it is a really confusing topic, or really he need much more clarity. You had made it very simple, that concept. And I think if you, we will take the questions over to chairpersons.
First of all, I would like to thank Dr. Amit Patki sir and Dr. Asha Bakshi madam, Dr. Fessy Lewis and Dr. Anu for giving me this opportunity to chair the session. Dr. Ashish, as usual, a very good talk. I had just two queries. You have avoided the use of gonadotropin on the day of agonist trigger. Is there any particular reason for that ghosting? And you said that I have heard previously also to keep a gap of 12 hours between the last dose of Antac and trigger. So how do you tackle your patients who take late evening injections? You must be having a lot of working class.
Yes. Nice question. First of all, let me clarify about the physiology of ovulation. All of us knows that, but let me know if you are giving antagonist is a suppression of the LH receptors. So we don't have the LH to go in, because that's why we start with a fixed dose or variable dose, whatever it may be. Whenever you are switching from the antac to the agonist as a trigger, the agonist has a potential to replace that LH receptors. And all of us knows there is a first is a flare up, and then there is a down regulation. This flare up, what we are used as a one of the entity as a trigger. So whenever you are having the flare up, as in my slide, if you see the SCG, there is only LH receptors and synchronicin. But whenever you are talking about agonist has a FSH and LH. And that's why in a different stimulation cycles also, we give that a hyporesponder, we give that flare-up stimulation, or maybe a microdose stimulation. Similarly, when we're talking about giving as a trigger, it first causes a flare-up in both FSH and LH. And that's why it is important to give that agonist of that particular gap. Because if you are talking about cetrorelix mechanism of action, it starts after 1 hour of injections, it starts for 4 to 6 hours. And that's why it is a short acting, and that's why every day we have to give. And there is only one cetrorelix dose is a 3 milligram, where we gave a prolonged for 4 to 5 days. That none of us practicing cetrorelix higher dose. And that's why whenever we are giving a cetrorelix along with the replacement of an agonist as a trigger, there has to have a gap of at least say 8 to 10 hours.
Thank you, Dr. Ashish, for a very nice and informative presentation. You have very nicely explained about the SCG, agonist, and the dual as a trigger, when to give them, and what are the advantages and disadvantages. Now, my question is what is your experience of having the empty follicle syndrome with SCG or with agonist?
Madam, if you are really asking me, empty follicular syndrome is an entity which has been designed and coined by the clinicians when they don't find any of the follicle. And now there is after that empty follicular syndrome, the question comes as a rescue trigger. Yeah. So why we talking about rescue trigger? That we, in the back of my mind, after aspirating the follicles of a one ovary, none of them are getting the M2 oocyte. It means that there is a problem in trigger. Because already you have a E2 levels in your hand, which will tell you this is the gonadotropins is been given. You have a follicles on the sonography machine, but nothing comes out. That means your LH receptors polymorphism is a very, very rare condition. There is the serine, and I will not go into the details of the receptors, but there are the certain polymorphism. And that's why in that empty follicular syndrome is accounting for a very, very less population. Otherwise, there is a problem in trigger, or maybe then you have to have a rescue trigger, or maybe a double trigger, what we talk about.
So how do you deal with such situation, like when we aspirate one ovary and nothing has come out? Do you repeat the other ovary and give the trigger?
No, I will not going to do the OPO of the other ovary. I'll wait, I'll give the second trigger, and then I will aspirate.
Okay. Thank you so much. Thank you.
Dr. Ashish, how many hours after second trigger? Second trigger, after respiration of one ovary. So how many hours after that trigger you will do pickup?
Usually when you're talking about second trigger, it means that there is a definitely your that first trigger is not worth. So ideally, when you are giving a second trigger, there is always because you are aspirated one of the follicles are going to go down. So usually when you give a trigger on that day of the OPU, we do it the same pickup and the same after the 34 hours. I will not do it after the next 24 hours. Never ever.
Sir, your rescue trigger?
There are the two school of thought. I definitely know about it. Some of them just do it next day. But frankly, talking to all of you, whenever you are doing that things, how many of you are really found out the follicles? Just mark me in a private message, and then I will answer it very happily.
Sir, your rescue trigger is a dual trigger, or is it only?
I will change the trigger. If I'm giving a SCG trigger, then I will change the trigger according to the cycle. Because if it is an antac cycle only, then and then only I can use agonist trigger. Otherwise, I will not be using any of the trigger. Thank you.
Thank you.
Thank you. Thanks, sir.
Wonderful talk, Dr. Ashish.
Thank
Great
you.
talk.
Thank you very much. And thank you for patience hearing.
Any other questions?
So I think we'll invite our next speaker. Dr. Fessy, will you please invite the chairpersons?
Sir, you're on mute, sir. Fessy, sir, you're on mute.
Okay. For the next session, we have got chairperson. First, we have Dr. Shivani Sachdev Gaur, and she's the ex-clinical research fellow, Imperial College of Hammersmith Hospital, NHS Trust, featured in the Limca Book of Records, founder secretary of Delhi Chapter of ISAR, General Secretary of INSTAR, General Secretary of Delhi Chapter of ISPAT, ex-Vice President Delhi Gynec Forum South, and Vice Chairperson of Women Doctor Wing IMS South Delhi. She has got a lot of publications, more than 10 special awards and recognition like Rashtra Gaurav Samman and Rashtra Ratnam Samman from the Minister of Women and Child Welfare, New Delhi. Member of Editorial Board of International Journal of Reproduction, Contraception, Obstetrics and Gynecology, Limca Book of Records for Surrogacy, Public Awareness Organized for third-party assisted reproduction, that's INSTA. And then we have the second speaker, Dr. Pragya Misra. I think she is the Secretary General of ISOPAR and for two terms, and ICOG Governing Council member, Chairperson of Genetic and Fetal Medicine Committee of FOXI, 2016 to 2018, and Founder Secretary of Bihar Chapter of ISAR, and Vice President Patna Obstetrics and Gynec Society, and Secretary of Patna Obstetrics and Gynec Society, examiner of MRCG clinical exam, imparts FOXI certified colposcopy training awards, several awards she has got, and contributed chapters in 10 FOXI publication books and paper in national journals, and organized Secretary of FOXI LaborCon 2023 Patna. We welcome Dr. Pragya here. And third, we have chairperson, we have got Dr. Rimi Singla. She's the Director, Radiance Hospital and Test Tube Baby Center, Mohali, Punjab. Medical Director of Singla Mediclinic Laparoscopy Fertility Gynec World. President Mohali ONG Society. Treasurer ISAR Chhattisgarh. And Founder Secretary of Mohali ONG Society. Chairperson Disha Women's Welfare Trust. Member Women Wing of IMA Chandigarh, and life member of several associations. She was invited faculty at various state and national conferences, promotes health awareness through seminars and writing. Among the pioneers in the region for developing cosmetic gynecology clinic, one of the first in the region to initiate PRP and stem cell therapy in infertility. And she has been awarded Rashtriya Swarnim Hind Award 2019 Best IVF Specialist in Punjab by the International Healthcare Awards 2070. And our two chairperson. And I think we have Dr. Rajesh Kordia talking about the progesterone in ART. I think the chairpersons will introduce the speaker. Over to you, chairpersons.
Should I introduce him, Dr. Fessy?
No, you introduce.
What?
Yes, sir.
You
Yes,
can
yes.
go ahead.
Introduce कीजिए, ma'am.
Okay. So we have Dr. At the outset, I would like to thank ISAR Central Office Bearers, especially Dr. Amit Patki and Dr. Anu, who's in charge of this ISAR Catalyst series, along with Dr. Fezi Louis. So I have the pleasure and privilege of introducing Dr. Rajesh Koradia, who's a senior obstetrician, gynecologist, and infertility specialist. He is a pioneer of IVF and endoscopy in Mirag, Bhayandar region. Well, we heard Dr. Prakash Trivedi say that he has learnt his IVF from Rajesh Koradia. So we cannot have a better introduction of him. He's the medical director of Meera Bhankar Institute for Reproductive Assistance, and he has a vast experience and interest in the field of evidence-based infertility teaching and community IVF. So I think Dr. Shivani, would you like to introduce the subject?
Subject?
He's going to speak on luteal support in ART. There was slight change in program. They swapped the timings. So,
नहीं ma'am, I'm saying कि let him start. Dr. Rajesh, most welcome. We are waiting and waiting to hear from you. So please go ahead. Ma'am, we'll leave our questions to after the presentation once we've heard Dr. Rajesh.
Sir, you're on mute. Dr. Rajesh, sir, you're on mute.
Thank you so much for having me here. I'm happy to see you all after a long time.
Sir, can you share the slide?
Yeah. Can you see?
No, sir.
You cannot see?
No, sir.
No, sir. No, sir.
Not yet, sir. So you are using the share icon at the bottom.
Share content.
Sir, just is your slide deck open? File is open?
Yeah.
Yeah, so just use the share icon at the bottom and then it will give you the option to choose a window of your slides.
I'm using my iPad. So I'm sharing the screen, I think. Am I right?
No, sir, not visible in the Zoom platform.
Then I thought it should work.
No, sir, first open that slide, then go to the Zoom and then share, sir.
So I open the slides. Okay, then
go to the minimized Zoom and make it big without minimizing the slides.
Okay. Now, no.
राजेश सर
Just a minute.
राजेश
I'm
सर
sorry.
आपके पास लैपटॉप है अपना तो उससे try कर
Yeah, just a minute.
So you want to try and
Sachin क्या है?
so you want to message in this Zoom platform itself your slide deck as an attachment? I can try and download and share it. in the chat if you want to share it.
So what should I do?
In the message, if you go chat message, there's a attach option. So if you can attach your slide deck file and message it, then I can
share and export. Okay.
In the Zoom chat you are doing so.
Share. Okay. It's a PPTX is fine, ne? PPTX format.
Yeah, yes, sir.
You know, this generally happens when there are a lot of cookies, and also to delete all your browsing data, switch it on and off, join the Zoom again, and only then you can upload.
Okay, I'm sharing the
I've
file.
learned from experience. I had also hang up like this. So what you have to do is clear all your browsing data, then switch your computer on again, join it again, and then you are able to present.
I think Rajesh said it's best that you get your laptop and start with that. It'll be faster.
Okay.
No, but Dr. Shivani, from my experience, just like Dr. Fezzi Louis was saying, I think if you
Give me
it's
1 minute,
always better
please.
to open the presentation and then click on share. Then it works.
He's
If you
doing
go
that,
to
but it's
Zoom
not.
share and if your presentation is
He's doing that, but that is not working. If
but
that is
sir,
not working, there is no option but to
sir,
leave
open the
and join
presentation. Don't make it. In a full screen. Just open the PowerPoint. Not make it in the screen share view.
Okay. 1 minute.
Just open it.
Okay.
PowerPoint. Close it and open it again.
Fine.
And don't make it in the screen share mode. And then go below to the Zoom and open it again and then share it. Don't make it full screen.
Okay. Yeah, I have opened in PowerPoint now.
Don't make it full screen. Don't make it. But PowerPoint, we can see the slide and the other slides in the one side. At that point, you would go to the below and take the Zoom and open it again. Just open the Zoom, which was already opened.
Okay, open.
And then share it.
Share screen, ne?
Share screen. Why? No. Don't share screen, not the stop video.
No. Are you able to see?
No, sir.
No, sir.
Now your video is off. Don't off the video. Oh yes. Now just the green share area you have to share. Share
content. But then screen photo.
No. Double click on that, sir. No. You are closing the stop video. No, not that. There is a green share screen. No. Don't
Green.
Don't off the video.
No, I'm not making the top. Sasi ne bola mujhe. Right.
Just share screen.
See, PowerPoint is open.
No. Again, you are made the video is getting off. Don't off the video. Your name is coming and your video is getting off. Don't off the video. Yes.
I'm not. Yeah.
Now you are seeing the share screen. You are seeing share screen green arrow. You are seeing
where
below in the Zoom.
No. 1 minute.
Why we are not seeing the show?
Just
you are doing in the laptop or PC?
iPad. It's iPad.
iPad. Not the laptop. Huh?
No, it's iPad.
iPad may not have the PowerPoint option sometimes.
PowerPoint is there.
Then this now you are again off in between. You are offering the video. In
Sir,
the Zoom,
iPad has, even I'm using iPad, Dr. Rajesh. It
Yeah.
has a share arrow in the bottom. A chat, reaction, share. Share arrow is there.
Share
screen.
Reaction, yeah.
Share
Chat
screen
reaction.
green.
It isn't green here. It is in black and white only.
Oh my God.
Dr. Rajesh, can you share your presentation on Nakul's mail? He can share
Sir,
your
I've
presentation.
just shared an email ID. If you
I
can,
can. Sorry.
You can
My-
forward to the email ID which is there in the chat. Nakul has
Okay.
just put it on the chat. If you can open the.
Kalpita बोला. एक minute, just a minute.
So if you can open the chat, there's an email ID pasted there, manish.garg@.
Yeah.
So if you can just forward it there, then I can share the slides. manish.garg@unsc.co.in.
एक minute.
आप प्रेजेंटेशन नहीं तो व्हाट्सएप कर दीजिए, कोई भी
एक
शेयर
minute.
कर दे.
मना presentation करें ना.
Presentation करूँ sir.
See, this is presentation. I want to share. Zoom is on.
Now your video is off.
Yeah, this is Zoom. So presentation.
Send the presentation to that email ID. They will share.
Okay. एक मिनट email ID पर कर रहा. See, send this on this email ID. Presentation. Copy this email ID.
The one Manish.
Copy. Yeah. I'm doing that.
Yeah.
एक मिनट presentation तो पहले open कर.
Is it in the PDF format or PowerPoint format?
This presentation. Yeah. Send a copy. Yes. Mail. Okay. Yeah, I'm sending. I have sent.
Yes, sir. I'm just.
Sir, can you check in your iPad, is it in the PDF format or the PowerPoint format?
Presentation.
Dr. Manish, have you received that presentation?
Not yet.
Okay.
Yeah, now. I'm really sorry. Have you received, Dr. Manish?
Yeah, no, not yet, sir. I think as.
Sir, can you WhatsApp?
Or the one more email ID, nagul.patil@unsc.co.in. Send one more copy in that. And manish.garg@unsc.co.in.
Please speak again.
NAKUL. AKUL.
NAKUL. Nakul.
Dot
PATIL.
Sorry.
Dot PATIL. Patil.
Sir, what message it's written?
At unsc.co.in. UNSC.co.in.
.in. Okay. Yeah.
Send.
Done.
Send one more copy in manish.garg at unsc.co.in. MANISH.GARG
Yeah, both of you said.
at unsc.co.in.
Yeah. I have sent to Manish Garg and Nakul Patil.
Have you received?
Not yet, ma'am.
Manish.garg.
Sir, do you have your laptop around? आसपास है?
No, I
तो
have
आप
sent
उसमें
to
लॉग इन कर लीजिए.
See, I have sent to nakul.patil at unsc.co.in.
Sir, has it gone out of
Yes,
your
yes.
outbox, mailbox?
Yes.
So must be on the way then.
Do you have a laptop or a PC?
Manish Garg also you have sent.
WhatsApp?
Manish.garg at unsc.co.in. Can you do something?
WhatsApp?
स्क्रीन शेयर पापा स्क्रीन शेयर करવાનું છે
શું
સ્ક્રીન શેર કરવાનું છે
WhatsApp कर दो. WhatsApp कर दो.
Sir, I've got your presentation. Just a minute.
Okay, sir. Chalo, thank you. Thank God.
I'm just opening it. Just give me a minute.
Yeah.
So I hope the slide is visible now.
Is it visible? Yeah.
Yes.
Yes.
So fine. Can I go ahead?
Yes, sir.
So from where to change there? Okay.
So just let me know when you want me to change the slide. I'll move it ahead.
Yeah.
Yes, tell next.
Yeah. This was original talk because progesterone is sometimes double-edged sword, and sometimes it is higher levels are beneficial, sometimes it is harmful. Depends on the indication. So there are principally three sources of progesterone, as we know: adrenal, ovary, and placenta. And the physiological level of progesterone, which ranges from 0.23 nanogram in ml in the follicular phase to 8.3 to 25 nanogram ml in the luteal phase. And pregnancy, it is quite high. Next, please. So, role of progesterone, we all know the most important role as far as the ART concern is immunomodulatory action, because that's the principal action in which we look forward, and because it inhibits the tissue rejection and protection of the conceptors. And this is done by positive shift to TH2 dominance. So TH1 to TH2 ratio is very, very important. And it is done by regulation of the progesterone-induced blocking factor, NK cell, HOX10, trophoblast HLA gene regulation, etc. Role of LH in progesterone production is very, very important. And it's basically balance between HSD mechanism and 720 lysis activity, hydroxylase lysis activity. So if one activity is higher, then LH cause rise in progesterone. And if it is predominant by HSD activity, then the progesterone level is lower. So it is not very properly understood exactly in the later half of the stimulation. If you add LH activity, it helps or it increases the progesterone level, because ultimately it depends on the balance of two mechanisms. Next. So how about the early follicular P elevation? Whenever the early follicular, or maybe on the day of trigger, if the progesterone is less than 0.5, it is not very ideal level. And we expect the progesterone level to be between 0.5 to 1.5 nanogram. Of course, the single level does not decide, or single level, the progesterone level does not reflect the actually say activity of the progesterone, but still for practical purpose, we have to rely on that because it provides some base. Why there is an early follicular P elevation? The principally it is maybe because of the incomplete luteolytic activity and persistence of the corpus luteum activity, and this is principally happens in aging ovary, and sometimes very rarely it is a adrenal origin. And because of this, there is a suboptimal hormonal milieu for follicular growth due to corpus luteal activity, and there is deranged endometrial receptivity. So, what solution suggested? They say some of the studies say you should delay the start of gonadotropin stimulation. Some say you give antagonist treatment for 3 to 5 days and then start stimulation. And if you think that everything is fine, but it is adrenal origin progesterone, then you have to give glucocorticoids to suppress the adrenal origin of the progesterone. But at the end result, whenever there is a rise in the early follicular P, the P level remains high at the time of trigger, and you are not able to transfer the fresh embryos. And definitely there is some compromise and fall in the pregnancy rate. Next, please. So why the P elevation during the follicular phase of the stimulation? We all know it is because of the multifollicular development. I do not want to go into that too much detail of physiological details. During what happens, the hyperstimulation, the more follicle produces more progesterone, which is beyond the capacity of the CYP17 enzyme to convert to androgen. So unconverted progesterone is liberated in the circulation, and which is responsible for the P elevation. And that's the reason it is one of the suggested strategy. If you want to avoid a P elevation on the day of trigger, your stimulation should be very mild in last 2 days, so that new follicles are not recruited, and these newly recruited follicles are not going to be helpful as far as giving the pregnancy, because they are not going to give the mature oocytes. But then definitely it supplements the progesterone, in which may deteriorate or hamper the window of implantation by shifting the window of implantation. Next, please. So, what is the impact of longer stimulation, especially when raised basal LH level? There is a high androgen production in the theca, and because of that, there is a high conversion to E2 under the effect of prolonged FSH administration. So, there is a more expression of the progesterone receptor at endometrium. And what is the end result? Even a small progesterone level can enhance the secretory transformation, and it can disturb the window of implantation. So you have to be very careful, especially when there is a longer stimulation. Stimulation may be lasting for 12 days, 13 days, or 14 days. Next. So we all believe that when there is a rise of E2 beyond 200 and it remains persistent rise, and that's a trigger point for LH surge. But now the concept has been changed. Only estrogen is not enough to initiate the LH surge. What is the proof of concept? Continuous usage of aromatase inhibitor while follicular phase leads to low E2 level, persistent. Still, the ovulation and menstruation is not affected. Evidence number 2. During the ovarian hyperstimulation for IVF, the supraphysiological level of E2 is reached very early, but still it does not trigger the LH surge so early. 3. Boosting E2 level 10 times by externally supplemented estradiol does not initiate the ovulation in normally menstruating women. So that itself, these 3 facts proves that it is not only the estrogen, there is something beyond that. Next, please. So progesterone is a new trigger to LH surge, because it has been observed that intramuscular progesterone raises the gonadotropin level, similarly LH surge. And progesterone start rising to cause 0.5 nanogram 12 hours before the estrogen peak. Before the estrogen peak, the progesterone start rising, and which is a trigger point for LH. Next, please. So in that cell, progesterone rise is suggesting follicle readiness. Because what happens when the follicle gets mature, we all have observed that there is increased vascularity, more than 3/4 vascularity. And because of this excessive vascularization and inflammation, there is a inflammation and increased oxygen supply, and because of that there is a suppression of the endothelin 1, which is an inhibitor of the progesterone synthesis and which causes increased progesterone synthesis. Not only this, it is also suggested another theory that just before the trigger, the follicle loses the integrity and there is a change in intrafollicular hormonal milieu, and which causes spontaneous utilization of the part of the granulous cells and which is responsible for progesterone rise. Next, please. So what happens when progesterone rises 50% above the average follicular level? It acts on progesterone A receptor in the hypothalamus, and which has a capacity to modulate GnRH pulse. So FSH and LH surge is initiated. Next, please. So when there is a persistent high progesterone level during the follicular phase, which happens in progesterone prime protocol, the LH surge is not initiated because there is a higher progesterone cause desensitization of the P receptor, it proxy GnRH receptor, and it was earlier believed that it drained the pituitary of LH and FSH, but it is not true. And because even after progesterone prime protocol, when you give agonist trigger, the LH activity is much better as compared to the non-PPOS protocol. So that condemns the theory of draining pituitary, LH, and FSH. So most accepted theories is it causes desensitization of the P receptor. Next, please. So persistent low level, is it important? Yes. It allows LH to accumulate and P receptor to sensitize. So when P rises above the basal level in late follicular phase, it causes LH and FSH responsible for ovulation. So low level has to be maintained during the follicular phase. Then and then the LH surge can be initiated in the later half. Next, please. So the conclusion, progesterone is a physiological trigger for LH surge. Once the follicles are ready and primed with the estradiol. Next, please. So P and the trigger day. The largest meta-analysis of 60,000 cycle concluded that more than 0.8 nanogram is associated with the negative correlation of the pregnancy achievement. Now, there are different studies and different cutoffs are given. Ultimately, it depends on which protocol you're using, which gonadotropin which you are using, whether it is an antagonist protocol, long protocol, whether you are using pure FSH, recombinant FSH, HMG combination, how many depends on how many oocytes are there. So it's quite confusing. So when really you want to keep the cutoff, normally I keep cutoff 1 or 1.2 maximum. Even if 1.3 or 1.4, I never intend to try a fresh transfer. So sometimes another question asked, high P4 level is detrimental to oocytes. So most of us believe that even if progesterone level is high, if we transfer the embryo in the frozen embryo cycle, not the fresh cycle, the pregnancy rates are unaffected, which is not completely true. So when the progesterone level is more than 2, such high level is detrimental to the oocytes. And even if the embryos formed out of these oocytes are not going to give a good pregnancy. So this has to be understood, because after the recent studies, most of us, they have start bombarding with the higher dose of gonadotropin, because many of the studies, they have concluded that higher gonadotropin doesn't affect the oocyte quality, one, and the cumulative pregnancy out of one stimulation is higher if your FOT is higher. So everybody is tempted to use a very high dose of gonadotropin, and which is really detrimental, because if you use a very high dose of gonadotropin, irrational high, I would say, then it causes a very high progesterone elevation in the later half of the cycle, and which is a detrimental to oocytes. So that you do not realize immediately. You are happy with the follicle output rate, but these oocytes are not good and they are not going to give you pregnancy. Next, please. Please. So what is the meaning of luteinization? Luteinization means serum progesterone is more than 2 nanogram. There is a subtle rise beyond threshold in agonist cycle up to 35% and in antagonist cycle up to 38%. So it is more common with RFSH and hyporesponse and OHSS. And the result compromise when the RFSH, when P is more than 1.26, when it is HMG more than 2.2, when it is combined 1.5, more than 1.5, cutoff based on response 1.6 for less than 5 oocytes, 2.24 for 6 to 9 oocytes, 2.5 for more than 20 oocytes. It's complicated. It's very difficult to, depends on the protocol. 1.2 for long protocol, 1.5 for antagonist protocol, 2 for filler protocol. So basically very difficult to remember. It is very difficult to analyze. So the simple formula and simple understanding I keep is whenever the oocytes are M2, I mean the oocytes are more than 12 to 13, I don't transfer fresh. If the oocytes are less than that and progesterone is less than 1.1 or 1.2, then I try to transfer the fresh. Okay, next. So P elevation on the trigger day, and still if you want to transfer fresh, it is said that there is no more advancement of the endometrium, which I found 7 days after the trigger. So when there is a progesterone elevation and still if you want to transfer fresh, it is better to transfer blastocyst because endometrium recovers during window of implantation only by that time. Next. So this we have discussed more than 2 gram, reduce top quality embryo and top quality blastocyst. Yeah. Next. So what is more important is progesterone follicle index. That is reflected by progesterone in nanomole divided by liter, divided by the number of the follicle more than 14 millimeter. So if the follicles are less, say I would say if there are only 2 follicles, and if the progesterone is 1.2, then one should not transfer fresh because progesterone per follicle is quite high. So ultimately, you have to consider the number of the follicles also. Next, please. The significance of the progesterone level 12 hours after the trigger. This is very important slide because this is very helpful. So the post-trigger, progesterone starts rising and within 24 hours, it becomes 5-fold. This all figure you should remember. Ideally, 12 hours after their trigger, may it be agonist trigger, may it be your HCG trigger. Ideally, it should be more than 3 nanogram or at least 2-fold higher than before trigger level. So if you really want to understand the whether trigger has acted, as my previous speaker also mentioned about the 12 hours post-trigger measurement of the LH and progesterone level. So progesterone level, I would believe more on progesterone level rather than LH level, because that's the clue of luteinization, and that luteinization only happens if the trigger has acted. So we have to measure the trigger day progesterone. We have to measure 12 hours post-trigger, and that gives fair idea. If the levels are normal, you are not going to get empty follicle in any circumstances. So if the progesterone is more than 6 nanogram, it suggests, I'm talking about 12 hours after the trigger, it suggests the early secretory transformation of the endometrium and closure of the window of the implantation. It is also said that P level on the trigger day, if it is more than 1.7 nanogram, and 12 hours after the trigger, if it is more than 9.5 nanogram, it substantially reduces the implantation rate. Even if, suppose you are not measured, suppose your basal level is normal, and 12 hours post-trigger value is higher, still it reduces the implantation. So you should freeze the embryos. So progesterone levels are very, very important for two reasons. One, if you want to understand the possibility of the empty follicle syndrome, and two, if you really want to take a correct decision of breast transfer. Next, please. So this has been discussed, progesterone rise, and with SCG trigger, there is no LH rise. And with all the other trigger, you got agonist trigger, there is a progesterone rise. Next. So when you are using DHA, it sometimes cross reacts and gives falsely high progesterone level. It's just a word of caution. Next. So how about the low level follicular P level? If the P4 is less than 0.5 nanogram per ml on trigger day, it reduces the live birth rate because it suggests the oocyte quality unaltered, but reduces the live birth rate, maybe because of the decreased luteinization and altered endometrial receptivity. So what is the solution suggested? Of course, doesn't work much, but then solution suggested to step up the FSH or maybe postponing the trigger and providing early luteal support. So whatever best you can do for this patient. Next. So how is the progesterone level when the endometrium is ready in frozen embryo transfer cycle? So cutoff level is less than 1 nanogram, which is suggestive that there is no chance of premature LS surge. And so cutoff level should be considered 1 nanogram in HRT and transfer cycle when the endometrium is ready. So progesterone level on the day of ET in FET cycle. Now, you have to understand the progesterone level on the day of ET, the significance differs in natural cycle, modified natural cycle, and HRT cycle. In natural cycle, it doesn't play any role. Even if whether progesterone level is low or progesterone level is high, the pregnancy rates are not altered. I'm sorry to say, the pregnancy rates are not altered in natural cycle. When it is a modified natural cycle or when the SCG trigger is given, the significance is different. There are some studies which says that even if the SCG trigger is used, it should be more than 9.5. But in HRT cycle, it correlates very well. And many of the studies, they have proved that the progesterone level should be more than 9.5. And optimum is 17 to 30 nanogram. But if it is less than 9.2 nanogram, and if it is more than 125 nanogram, that deserves the cancellation of the transfer. Now, the progesterone, serum progesterone level, if you are using just a vaginal progesterone, then it is not always a correlating. In some of the patient, if you observe, the serum level is quite high, and in some of the patient, the progesterone level is not very high. So it is not absolutely well demarcated, the serum level correlation with the vaginal progesterone. Now, serum level of the progesterone is very, very important. And the highest serum level is achieved only by intramuscular progesterone. And the optimum is more than 13.6 nanogram if you are using intramuscular progesterone. So in obese patient, because of the vast distribution of the lipophilic drug, the levels are lower. And if you want to maintain a good serum level, you need to give higher dose of intramuscular progesterone. The American people still, they believe in giving intramuscular progesterone. And European, they are preferring more of vaginal progesterone, maybe combining with the oral dydrogesterone. There is a study which says the increased vaginal dose more than 600 milligram per day increases the pregnancy rate and reduces the abortion rate in frozen embryo transfer cycle. So if you review the literature, there are a lot many studies which says that progesterone level on the day of transfer is less than 9.2 nanogram. the pregnancy rate is not good. But very few studies who talk about the higher level of progesterone. So in other way, we can presume that higher level of progesterone are not that harmful, but it should not be in a very early luteal phase of the cycle, not immediately when you start progesterone. You should not bombard with the higher progesterone level, because the progesterone requirement is for two reasons. One is for secretory transformation, and then changing the receptor gene profile. The changing the receptor gene profile and implantation is very, very important. Maybe once you start progesterone, maybe 5 or 6 days of the progesterone, because that's the time where the implantation is going on. So at that point of time, the progesterone level should be good, high, but you should not start with the which is a common practice of most of the IVF centers. They start with the vaginal progesterone, they start with the intramuscular progesterone, they start with the gel, they add dydrogesterone also. On the contrary, you are hampering the result, because too much level should high progesterone good in early luteal phase can change the window of implantation. Next slide. So how about the pre-ovulatory progesterone elevation? So pre-progesterone elevation for 2 or more days before LS surge affects the pregnancy rate. So what is important? Just single value of progesterone elevation on the just before the day of LS surge is not important. It is a persistent progesterone elevation for more than 2 days is important. Next. So progesterone prime protocol, I think we are running short of time, and we have started shifting to the progesterone prime protocol because definitely it prevents the LH surge, and it is very economical. Lot of many studies they have proved the utility, the success rate, clinical pregnancy rate is not different, but only thing you cannot transfer fresh. There are different way of using progesterone. There are few people who believe in starting progesterone right from the day one, stimulation day one. I am the one who believe in starting the progesterone exactly like I start antagonist in antagonist cycle. Unless if the patient is PCOS, then I start progesterone from right from the beginning. And the second scenario is one of the follicle is borderline asymmetrical. Say even follicle is say 10 millimeter, another all follicles are small. So in such scenario, I start progesterone right from the beginning. You can definitely use this protocol in all spectrum of the patient. May it be normal responder, may it be hyper responder, may it be a poor responder. Next slide, please. So these are the indication where we use progesterone time protocol. In short, when you do not intend to transfer fresh. Next, please. So this is again an important slide which compares the luteal phase of the stimulated cycle. Now, if you look at the slide, this is how a natural cycle where the progesterone concentration remains quite high till the late mid of the cycle, and then it falls down. So this is a phase where the implantation is going to happen. But if you give a trigger, like this is GnRH agonist trigger, and this is SCG trigger. So if you give SCG trigger, the progesterone in early luteal phase is very, very high. So which is again a cause of little worry. And second cause of worry is after 5 to 6 days, 5 days of the trigger, 5 to 6 days of the trigger, the progesterone starts falling, and which is the actual time where implantation is going to happen. So this is progesterone deficient period. LH activity is not there. So this is a time where you need to either supplement with the progesterone, or you need to supplement with additional dose of SCG if you're only relying on SCG. or you can start with the progesterone. So in my control ovarian stimulation with time intercourse cycle, whenever I'm using SCG trigger, I start progesterone at this level. Maybe 4 days after the trigger. I do not start immediately after the ovulation or maybe IUI. So when GnRH agonist trigger is given, the deficient LH activity deficient period starts maybe in 72 hours only. 32 hours only. So after that, there is a deficiency. So definitely that's the reason why, because of the luteolytic activity, and that's the reason why we do not prefer to transfer flash when agonist trigger is used. Next, please. So these are the different theories why luteal phase defect happens. Next slide, please. So progesterone is really needed after clomiphene? No need, because the LH during the clomiphene cycle remains quite reasonably high, and which takes care of the progesterone level. Letrozole, the evidence is not sufficient, but recent studies are suggesting even the progesterone usage is not needed in letrozole cycle. But whenever you are using gonadotropin, definitely because of the multifollicular development, there are chances of premature, there are chances of luteal phase defect up to 30%. And there is endometrial advancement and glandular stromal dysynchrony in the luteal phase. So the luteal support is needed. So same truth with the CC with gonadotropin and letrozole with gonadotropin. So whenever gonadotropin is used, whenever IUI is done, I always give a luteal support. Next slide, please. So what are the types of the progesterone preparation? You all know. Next, please. So I would like to draw your attention in vaginal micronized progesterone. Although it is a most preferred progesterone because there is a hepatic bypass, but the achievement of the endometrium level is very, very quick. And sometimes this quick achievement of the endometrium level is harmful. There are theories and there are apprehensions that it causes rapid endometrial advancement. So if even in one of the study it is suggested that if you are relying on vaginal progesterone right from the beginning, you should transfer little early because there is an advancement of the endometrium. You should transfer little early, not exactly according to the embryonic stage. Other problems are vaginal irritation, we all know. It changes local microbiome and which leads to progesterone resistance endometrium. So this was something about the vaginal micronized progesterone. Intramuscular, we all know it's painful. So we have switched over to subcutaneous progesterone aqueous injection. But the problem with the aqueous injection, 25 milligram is little less dose, and sometimes there is a breakthrough bleeding. So we use a 50 milligram subcutaneous aqueous injection. Oral dydrogesterone is an excellent drug to keep in your armamentarium of luteal support. I definitely combine it with the vaginal progesterone and aqueous. I use a combination, not bombarding with the all at a time, but in a different time. And the oral dydrogesterone is always used in all my luteal phase support because it has got tremendous immunomodulatory effect, and the level achieved the progesterone levels are achieved very quickly. And but only thing it does not reflect in serum your serum normal progesterone level. For that, a separate assay is needed, and it has no affinity for androgenic, estrogenic, and adrenalic receptor. So it's my preferred drug to use in luteal support. Next slide, please. So what is the dose? If it is a vaginal gen, 90 milligram daily or 90 milligram, little higher dose in HRT cycle. Vaginal 200 to 400. If it is 400, sometimes used 2 times. People uses 400 3 times. I normally use 200 milligram 3 times because I am combining with the aqueous progesterone. That's the reason. The oil preparation, 50 milligram, ideal dose, 100 milligram is little higher. But for HRT cycle, or it's American approach, for HRT cycle where agonist trigger is used, and still if you want to transfer fresh, you need to use 100 milligram. Oral dydrogesterone 10 milligram TDS. In HRT cycle, they suggest to make it 20 milligram BD. So little higher dose they are suggesting. The next slide, please. So this we have already discussed. Fine. Next. So timing to start progesterone, I always I never start, even if I intend to transfer fresh, I never start progesterone immediately on the day of pickup. Never in my life, because I strongly believe that if you use SCG trigger, there is a very supraphysiological higher progesterone level in early luteal phase, and there is no need of providing the progesterone. Because I'm worried about the change in the window of implantation. Of course, the GAO work has clearly indicated that early onset of LPS on the day of OCR does not cause premature closure of window of implantation, but still I'm cautious enough not to start immediately. Now, what are the advantage? If you start progesterone on the day of OCR, it makes uterus quiescent on the cleavage transfer. But if you are transferring blastocyst, it does not make any difference, because uterine quiescence achieved as early as 4 days after LS surge, whereas 6 days later in the stimulated cycle. So that's the time to transfer the embryo. By the time blastocyst, by the time the uterus is quiescent. Next slide, please. So this is about dydrogesterone. I think this is a pharma literature, and we all know it has a quick onset of effect, and is a long stable. It is beyond our Dr. Amit Patki's work on dydrogesterone in the best possible way, and he has clearly proved that it is a drug of choice in luteal support. It can be used as a sole luteal support, which I sometimes use no other progesterone, only dydrogesterone when I'm transferring embryo fresh. I completely rely on dydrogesterone without disturbing the resultant pregnancy rate. But if it is a HRT cycle, I'm not still confident to rely absolutely on dydrogesterone. I usually combine with other modalities of the progesterone. Next. So this is about dydrogesterone. Next, please. Next slide, please. Next slide, please. So that's the end of the presentation. I'll be happy to welcome any questions.
Thank you so much, Dr. Rajesh sir, for such a beautiful presentation.
Thank you so much.
And your concepts are so clear. It is just remarkable. I would like to ask you about this new extended release preparations which are available now, like 20 milligram, 30 milligram, this dydrogesterone. What is the role, and are you using these?
So those 20 milligram sustained release dydrogesterone, whatever studies they are having, it is used in the endometriosis. The studies which they are showing is use of sustained release in endometriosis. Still, there are no reliable studies to use sustained release as a corpus luteal support in IVF cycle. So I don't use sustained release preparation of dydrogesterone.
Wonderful presentation, sir.
Thank you, sir. Thank you,
I
madam.
know we have so many questions to ask to you, but we are getting late for a panel discussion.
Yeah,
So we'll start our panel.
sure. I'm really sorry if because of me there is a delay. I'm really
No,
sorry.
Sir, but it was a wonderful presentation. So we are going to a panel discussion.
Yeah.
Interesting case scenarios in infertility. And our moderator is Dr. Seema Pandey. Please kindly show her CV. she has done, Dr. Seema Pandey, she has done fellowship in minimal invasive surgery.
It's okay. Thank you.
Seema Di, please call your panelist. We all know you.
Yeah. So you call your my panelists because the slides are at your end. So Dr. Surabhi Singh, she is director of Surabhi Hospital and IVF Center, special interest in high-risk pregnancy, infertility, and endoscopy. She is recipient of Uttarakhand State ISAR Appreciation Award and 2024 100 Most Powerful Female Healthcare Professionals. Wow. Welcome, Surabhi. And our next panelist is Dr. Sabita Dikshit, who is from Allahabad and MRCOT gynecologist and IVF specialist. She is managing director at Dikshit IVF and Test Tube Baby Center. And she is co-author of book Demystifying Endometriosis, member of ISAR, IFS, and many other organizations. She has many accolades and awards to her credit. Brand Icon by Times Group, Unsung Hero by Foxy 2018, Youth Icon of the Year, honored by various social organizations for contribution in health sector and felicitated by Danik Jagran Group. Welcome, Sabita.
Thank you,
Our
ma'am.
next panelist is Dr. Jaya Sharma. She is Director of Global IVF and Rajmata Hospital, Aligarh, specially dedicated to fertility and laparoscopy. She's got awards like Pregnancy Care for Women 2016, Best Doctor for Women, and Prescription of Medicine. I welcome you on board, Dr. Jaya. Our next panelist is Dr. Meha Agrawal. She is Organizing Secretary, Srijan Histrocon, August 2019. She works as Director and Consultant at Srijan V Hospital. INEX Achievers Award Women of Substance 2019. And she's got first prize poster presentation in National Conference Foxy Aurangabad. She has many accolades: State President Medical Wing, Speaker Reproductive Ultrasonography, Chairperson Role of Nutrition, Allahabad Nursing Home Private Doctors Welfare Association. She has conducted cosmetic gynecology workshop and she has many publications to her credit like co-guided dissertation, role of diagnostic hysteroscopy and laparoscopy. And she is a state level badminton player. Wow. So welcome, Megha.
Thank you, ma'am.
And the youngest Turk is Dr. Yukti Bhardwaj. She is really a bright star. Star of Delhi ISAR, she's already got it. Youth Icon Award. And she's got many prizes. I know her as a quiz master. She keeps getting so many quiz prizes that we all are proud of, and she keeps presenting papers and poster at various conferences and keeps getting various awards and makes us proud. Welcome, Yukti.
Thank you, ma'am. Thank you so much. Thank you, Anu ma'am, for the opportunity and invitation.
So at the outset, I would just like to thank our organization president, Dr. Amit Patki, and our secretary, Dr. Asha Baksi, and the convener of this series, my dear Anu and Fesi. Thank you so much for making me part of it. I hope you can see my slides.
Yes, ma'am. If you can make it full
Can
screen,
you
ma'am.
see the slides?
If you can make it full screen, ma'am.
I have already.
Okay.
I did.
No, it has not become. Oh, yes,
Is
yes.
it still not full?
No, full screen, full screen.
Yes, ma'am. And now it's perfect.
Is. Yeah, I have made it full screen.
Yeah, ma'am, it's full screen.
I have made it a combined condition since most of our delegates and friends, they are gynecologists and they are gynae. Everybody is not doing IVF. So it's kind of mixed bag. And my first case scenario, these are all taken from life, names are changed. Mrs. Bhatia, 34 years, a teacher, married for years, and she has been trying to conceive since a year after marriage. her IT living abroad who comes for 2 to 3 months every year. Recently, she was diagnosed with endometriosis when she met a specialist. On her scan, she show multiple small ranging from 1 to 3 cm, and her present AMH is 2.25 nanogram per ml. So, lot of discussion took place, and before deciding on surgery versus IVF, couple wanted to try a few cycles of intrauterine insemination, as they have already taken multiple cycle of OI plus TIC. Both her tubes are present. Semen analysis has 34 million, 45% actively motile and 3% normal form. My question is to Dr. Sabita, do you support their decision?
Yeah, ma'am. IUI along with ovulation induction that can be tried because as endometrioma size is 1 to 3 centimeter and AFC is okay, AMH is also good, and the semen is near normal but not normal. So IUI can be tried for this patient, although they are having less time for togetherness, but still it can be tried because they want it.
Yeah, husband is of opinion that I'll stay for a few months and if
Yeah.
required, I'll change my job. But first of all, we want to go for the IUI.
Yes.
So Dr. Savita agrees to their decision and she says that she should be going for few IUI cycle. Now my question is to Dr. Jaya. Ask Jaya or Savita? Dr. Jaya,
Yes, ma'am.
what would be the best protocol for them if they go for an IUI cycle?
Ma'am, I would suggest the letrozole 2.5 for first 5 days, and after 5 days, 6 to 7 days, I'll follow with the follicle monitoring with endometrial vascularity. If it is growing well, otherwise I would add some
I start
HMG for few
progesterone
days,
right from the
7th,
beginning.
8th, 9th day, to make it better vascularity of follicle and the endometrium.
Okay, so
Then we'll
you will be going with mixed protocol of oral ovulation along with gonadotropin. Now, my question to Yukti, they have chosen gonadotropin IUI, right? Now, what will you counsel about to these patients, to this couple?
So we have to counsel them about the pros and cons of using gonadotropins in intrauterine insemination, ma'am. First of all, it will cause multiple follicular development. So there will be high chances of multiple pregnancy, and we should. Some of them will also have a doubt if the gonadotropins can increase the size of the endometrioma. So we have to explain to them that the studies have suggested that won't be any increase in the size of endometrioma with the use of gonadotropins, and definitely they have to be very particular with the ultrasound monitoring. They have to be ready for that. Whenever they are called for the follicular monitoring, they have to come for that. Yes.
Okay. Anything else anyone would like to add in this?
Madam, sometime with endometriosis, these patients end up in LUFA, luteinized and ruptured.
No, we'll come to that later, Dr. Jaya. My question is that this couple has agreed to go for gonadotropin IUI, and whenever you are going to do an IUI with gonadotropin, what are the things which you counsel and make them prepared beforehand? Yeah.
So there can be a high chances of cancellation if there is a multifollicular development.
development,
There might be a need to conversion to IVF if there see a lot of follicles there.
No, I have a point here. Since she has bilateral endometriomas, in the stimulation, we should counsel them that there are very less chance for you to get pregnant and for us to get the right size of follicles. And maybe we can start from day 2 only with a higher dose of gonadotropins and trigger her early.
Dr. Surabhi, but her AMH is right. She has more than 2 nanogram of AMH with 5 to 6 AFC from both the sides. Forget about she has endometrioma. What are the other, like Yukti said that she will be required frequent monitoring, and apart from that she'll have to come visit the center again and again. Fine. And
Yeah.
second thing, cost effectiveness. It
Yeah.
is
Cost.
an expensive thing, and as she rightly said that they'll have to think about the cost, because this cycle can be cancelled. She should be counseled about no response and hyper response both, along with multifetal pregnancies, not OHSs. I don't think she'll land up in OHSs, but if she gets multifollicular development, so about getting it either cancelled or conversion to an IVF cycle, if possible. So these are the things I think are the most important thing which we have to counsel them before starting the gonadotropin IUI. Fine. Now, coming to the protocol, as we all understand, and this very famous Diamond and Ligro, and we all understand that clinical pregnancy and live birth rate both are best with gonadotropin, be it endometriosis, unexplained infertility, or otherwise. But at the same time, chances of multifetal gestations are equally high, almost more than 30%. And that is the reason we are not telling, especially in cases of unexplained infertility, to go alone with gonadotropin. It requires real perfection from the side of the consultant, and clear understanding from the side of the couple, so that they are mentally prepared that this cycle, if it is multifollicular development, it might get cancelled. Coming to what is the problem with, what is the difference between pregnancy rate when we are using gonadotropin plus letrozole, clomiphene citrate? So that is almost similar, but we are using it just to save the cost. So this couple, they have decided to go for gonadotropin plus IUI. Precautions. Now we will come back to our basic question. What are the precautions we are going to take while starting the gonadotropin? Anyone?
Madam, just day to enteral follicle count and the size, whether there is any asymmetry. And ma'am, one more thing. In endometriosis, we always try to see by good TVS or 3D examination whether their ovaries are stuck or they are anatomically at normal position.
But we are doing intrauterine insemination.
Okay, at the time.
Does it make a difference, tubo-ovarian relationship? Or if we are going to do the oocyte pickup, then it can make tubo-ovarian relationship definitely makes difference in pregnancy.
Caution take while
But
using gonadotropin.
yeah. So first of all,
So,
tell
ma'am,
me, what will be your choice of
we should be
gonadotropin?
judicious with the use of gonadotropins. We can't use a very high dose of gonadotropins in
Yes.
intrauterine insemination, because of the high, we know that it will cause a multifollicular development. So we have to keep the dose of gonadotropins as low as possible, and we should be patient, and we have to call her. We have to counsel her for the regarding the ultrasound monitoring.
Okay. No,
So we
that
have to go slow.
you have already told that we'll be monitoring her. So first of all, our required dose should be whatever starting dose, that should be optimal or minimal. Not, we should go for a step up protocol rather than a step down protocol. Dr. Neha, what is your choice of gonadotropin? And do you use HMG or FSH for your IUI cycles?
In an IUI cycle, I'll prefer using HMG.
Excellent, yeah.
Because
so
of
what
its.
will you prefer in this case?
In this case, I'll start with HMG 75. and continue with my follicular monitoring. And if increase of dose is required, otherwise I would like to be stable on the dose. But if in between I feel that the increase of dose is required, then only I'll increase.
Okay. So Dr.
And
Surabhi,
Ma'am, I think 150 dose would be okay for this patient, isn't it?
Yeah, even
so
I
I'm coming to that. That's what I was going to ask to Dr. Surabhi. What are other parameters which you are looking at while deciding the doses of gonadotropin for this particular patient? One is AMH.
BMI of patient, BMI.
Yes, yes. So if we are going to do gonadotropin IUI for an endometriosis patient, she is not a hyperresponder. I think 150 dose.
50. I also.
And third parameter is her age, isn't it?
34 years.
So all these factors make 150 look quite promising. So 150 international unit of gonadotropin was started for how many days minimal? Dr. Dr. Sabita.
Yeah, ma'am.
How many days of gonadotropin you give first and then you call the patient for follow-up?
Ma'am, at least for 5 days. I will give gonadotropin for 5 days, 150 mg, and then we'll call her for ultrasound monitoring. What is the size? And we'll keep on giving it till the size is 18 to 20 mm, and then we'll give the trigger.
Okay. So, Dr. Jaya, suppose on day 6 of stimulation, you have started it on day 2, and the follicle size was one side, she was having one 10 millimeter follicle, and the other side, she had one 11 mm. What would be your protocol? How much dose increment or same dose? What will be your protocol from here?
Ma'am, from this place, I will add at least 75 international unit to this patient. If it is started with 150, then I'll add 75 to it for next 5 days.
And when will you call her again?
Ma'am, we can call her after 3 days. Once it is 11, 12, we can call it after three days.
Okay. So, Yukti, now this patient has come to you and 3 days after, and 50% increment of the dose was done, means she was on 225 international unit. And these two follicles got one became 16 millimeter, another became 18 millimeter. And what about the endometrium? And how will we proceed from here?
Okay. So the follicle development looks good, ma'am. And we have to see the endometrium. We expect it to be good since we have used gonadotropins for stimulation. And so I would expect an endometrium more than equal to 7 mm.
Okay. And when would you want to trigger this patient? And what will be your favorite trigger for this patient?
So my trigger would be an HCG trigger, and I would trigger at an follicle size of 18 mm.
One is 18, one is 16. Dr. Meha, do you look at something else apart from endometrium and the follicular size when you are going to decide the trigger in your IUI cycle?
I look at the flow in the ovary. At least 2/3 of it should be covered. Then it shows that it tells us about the maturity of the follicle.
Excellent. Yeah. So blood flow, you just put the color flow button around that follicle, and if more than 3/4 is covered, that means this follicle is ready to rupture and you can trigger. And especially it is pure gonadotropin cycle. So we are not waiting this follicle to go beyond 20 millimeter. So somewhere around 18 to 20, when you got good endometrium, you can go ahead with IOI. So IOI is single or double? Everyone.
Single IOI.
Single
IOI.
Everybody agrees that double IOI is not going to make any difference. Any other investigation would you like to do in this case?
investigation.
That
Any
progesterone
other
level is not
investigation
that
apart from scanning? If you don't do, it's not needed.
Yes.
Do you do, any one of you do any
No, no.
other investigation?
No.
Fine.
Ma'am, usually don't do, but
And the
progesterone level
ultrasound.
can be done. We do only ultrasound monitoring. I do only ultrasound monitoring, but progesterone level can be checked.
Okay, so everybody does the same, because for us, our ultrasound is our third eye and it is easily available. As per ASRM committee opinion, you can go for estradiol. And I would recommend, when you are having multifollicular or no recruitment, in that case, estradiol level can make a difference in your decision making. So that is not very important, as we are very expert with our transvaginal ultrasounds and it is really available to us. So these are two investigations. Progesterone, yeah, if it is more than 1.5, will you cancel or something? Do you do it in IUI? I don't think that we are
No,
doing
I'll not
that.
cancel. I'll go ahead.
Okay. Okay. Dr. Jaya, what about luteal phase support in this particular patient, and what would be your choice?
In this particular case, dydrogesterone is the best choice of luteal support. At especially TDS, it will improve her receptivity and endometriotic part. So
Yes, it
dydrogesterone,
takes care of the
TDS,
pain
10
also.
milligram TDS will be the best for her.
Okay, single oral dydrogesterone will be your choice. Any
Yes.
difference of opinion among my panelists?
I will give dydrogesterone and gel also. Renon gel 8%.
Okay. Why not vaginal capsule or pessary? Some specific reason for gel?
The results are better. The results are better with the gel.
Okay. Now IY was done everything. Now this couple is anxious about the progress of endometriosis and endometrioma with this gonadotropin cycle and IUI. So what is your opinion regarding that? I'll come to Dr. Meha first.
Ma'am, before starting the cycle and before putting her on gonadotropin, I do explain her that sometimes there might be increase of endometrioma, but side by side also explain her that if she conceives and if pregnancy attained, then definitely endometrioma is going to decrease.
Okay. So first of all, rightly said, it can be done. There is no other factor apart from endometrioma a couple. Now, have you ever thought of, like all of you are IVs, have you ever thought of GNR suppression followed by IUI for your endometriosis patients?
No, ma'am. No, ma'am. It will increase the
When
cost.
uterus is adenomyotic, then I use.
Adenomyosis, it has got good result, but not for endometriosis, ma'am.
Yes.
I have a different, I've done something different for small endometriomas and a younger age, 27 years of age. I gave her immunomodulation, that Dufaston for 2 months, and then I did IUI, and she got pregnant in the first attempt only.
So what was the immunomodulator, ma'am?
Dydrogesterone 10 milligram BD for 2 months I gave her, and then I started with the cycle stimulation.
And that Dufaston you started from which day, ma'am?
From day 2 of the cycle, because
Day
it
2 of the cycle,
affect,
throughout the cycle.
because it doesn't affect ovulation also, no. So
Yeah.
this day I asked her to be intimate also, but that didn't work. And
nice.
Can you hear me?
Yeah, ma'am.
Guys, activity for some time.
Yes, ma'am.
Hello. Can you hear? Yeah.
Yes, ma'am.
I had lost my network, so I missed it. So, do any one of you think about doing a long protocol for an IUI cycle in endometriosis?
No, ma'am.
No.
Yes, it's not practically feasible, but as per the theoretically, if we think that it takes care of endometriosis and results are good, but practically speaking, it's not worth trying. Fine. So regarding endometriosis progression, it is clear that whenever we are treating a patient for infertility with drugs
Ma'am, your
and
voice is breaking.
Ma'am, your voice is
injection,
breaking.
there
It's not
are
clear.
chances endo get affected, go into action mode. But yeah, you have to take.
Dr. Seema, there's some problem in your network.
So I'm saying that kind of treatment which leads to enhancement, like ovulation induction.
I think there is some problem with the network. Network is gone.
Dr. Seema, your voice is breaking, not audible now.
I think she left. Yeah.
Something, sorry, something is really wrong today. I don't know what's happening. Every
I
time.
think please off your, if the signal is weak, please off your video.
Yeah, I'll do that. I was going to thank you, Fessy. So yeah, IUI increases the chance, significantly increases the recurrence rate of endometriosis. So you have to counsel the couple, and that we keep counseling when you treat the disease. Fertility doesn't happen, and when you are doing a fertility treatment, there are small chances that you can get the recurrence. So this case is finished. Now my second case where Mrs. Rana, who is 29 years old, has been married since 2020 and trying to conceive for a year. She has been using a home ovulation kit and does not doubt that she has a doubt that she isn't ovulating. Though her cycles are regular, 2 to 5 days, 26 to 29 days with average flow, her AMH is 3.2 nanogram per ml, TSH 2.231, prolactin 23. Husband is a businessman, fitness freak with absolutely normal sugar, thyroid, and semen. Her natural cycle follicular monitoring was done, and she had a dominant follicle of 21 mm on day 12. On further follow-up, it did not rupture till 27 mm on day 18. So what next? I'll come back to Dr. Yukti now. Please tell me, what are we going to do now?
Ma'am, there are less likely chances of it rupturing. This might be a luteinized or ruptured follicle. So we can see the vascularity of the follicle, and we can do the LH and progesterone levels in this case, and then we have to counsel the couple, and we have to we can keep this in mind when we are taking her for IUI in the next cycle.
Okay. So no, IUI to, I don't know whether she'll agree to it or not. It didn't rupture on day 18 and it is 27 mm. Will any one of you would like to give a trigger at this stage? For gonad.
No,
No.
ma'am.
Okay.
No.
Okay. So as Yukti said that she will do LH and progesterone for this patient. So when will you do it and what are you expecting in that report? if you are thinking it is luteinized unruptured follicle.
So we are expecting a high LH level, ma'am. LH might be more than 15 and progesterone more than 3.5. So with even a high LH and progesterone, the follicle is not rupturing. So this is LUF.
Okay. And what is the 100% or gold standard to diagnose LUF?
So in in theory, it is written laparoscopy laparoscopy and testing the peritoneal fluid for the LH and progesterone levels can help us make a definite diagnosis. But we can do it on the basis of ultrasound.
Ultrasound monitoring, we don't see the fluid in the peritoneal cavity.
Yes.
And the follicle doesn't rupture, the follicular wall gets thickened up. There are fibrin-like strands in it. And it shows that it hasn't ruptured.
Internal echoes in the follicle.
Internal echoes are there, yeah.
Secretory changes in the endometrium. Yes.
Yeah. So
endometrium also, echogenic.
So what day will you choose for this particular patient to do her progesterone? Sometimes there is a small free fluid and we have missed it when we did, and she has refilled with the follicular fluid again. So what is the day when you do? Expected day of LH surge? How many days after if you do the progesterone and you can confirm that it is LUF or she has silently ruptured, we did not notice it.
Between days 14 and 20.
It is around day 21 in a 28 days cycle where you are expecting it to get ruptured on day 14 to 16. Or if you have given a trigger, then 6 to 8 days later on, you will be expecting a rise in progesterone. So regarding LUF, what are the other causes? Suppose this was a natural cycle and it has been said that it occurs more frequently in women with unexplained infertility. And is it a constant feature? Will it repeat in next cycle? We are not sure. And it is associated with stress and pelvic infertility, endometriosis. So it is also called this thing, psychological infertility, and it just gets corrected on its own. In your day-to-day practice, when do you get these kind of pictures like, and your follicle you gave CC and it did not rupture, you gave letrozole, and what are the reasons for those unruptured follicles?
PCOS and
Endometriosis.
advanced stage woman. So
obesity, PID.
First and foremost reason is that you did not trigger her at right time.
Ma'am,
And
like in this patient, it was a short follicular phase. It was a short follicular phase. She was 21 mm. She was having 21 mm follicle on day 12, and it was a natural cycle. But even with when we are giving letrozole or with the ovulation induction, sometimes we see very short follicular phase, and in these profile of patients like having PCOS and endometrioma or any inflammatory condition, this happens on higher side that luteinization is there and it's unruptured.
So this is more to do with that pro-inflammatory phase. And
Yeah.
later I came to know this patient was suffering from psoriatic arthritis, and
Yeah.
she had
She
been
must be
on
NSA.
methotrexate and etoricoxib for a long time, which she has
Yeah.
left for her fertility treatment. And it was stopped a month or two before though, but she was not doing. Later on, I left her for 2 cycles on natural support and she conceived on her own. Coming to next case, Mrs. Sinha, 30 years old, married for 3 years. She is a known case of PCOS and her previous reports show that she has an ovulatory polycystic ovarian syndrome. Her BMI is 24. Both the tubes are patent. All the reports are normal. how will you proceed? She is ovulatory PCOS, she is not conceiving, her BMI is also not very bad that we will go to lifestyle modification or anything. So, what will be your plan of action for this patient?
Ma'am, ovarian stimulation with the IUI, we can counsel her for that. She's been married for 3 years. She's a
Yeah.
ovulatory PCOS. The tubes are patent. Semen analysis, I think it is no. Yes, it is normal. So we can use letrozole for stimulation, and we can counsel her for an IUI.
Before that,
Ma'am, first of all, I like to talk to her. If she's having any problem in her family, or if she's under any pressure, I'll indirectly try to reduce her stress factor. And I will counsel her a bit regarding lifestyle modification. If she's not sleeping on time or she's not following a healthy routine, I'll counsel her for that.
Suppose, okay, she's doing everything, she's very educated. Now, my question is, she is an ovulatory PCOS of normal weight. Do you agree to that? So, she is phenotype C, fine. So, is there any role of any kind of adjuvant?
Yes, ma'am.
What?
And we can give the metformin for some time to improve her androgen activity and all that. The PCO condition is always a pro-inflammatory, and the combinations like Decaro and myoinositol, they really work if we give such adjuvant to these unexplained type of patients.
Okay. Any
Practically, these combinations do work, especially the combination of metformin with minoxidil and decanoxidil. That works in these kind of patients.
Yes, ma'am.
So we'll definitely try to pre-treat her.
And some of the timing of ovulation, we need to guide them. The lifestyle, a bit of regarding food.
No,
And simple follicle
everything.
monitoring and simple ovulation induction will do it.
No, she has done all those things. I'm not talking about that. Let's. I am saying other adjuvants. What one is myoino and metformin.
I'll check her vitamin D levels.
Yeah, vitamin.
Okay.
That is a routine practice that we do give vitamin
Any
D.
other investigation would you like to do? That is not routinely done. I mean, that is not recommended by the guideline. Okay. How many of you use oral contraceptive pills for these ovulatory patients for 2 to 3 cycles before giving ovulation
LH level.
I do, if there is synchrony.
So these are the
Ma'am, although because she's ovulating, that's why LH level I don't think needs to be assessed, but otherwise high LH and high androgen level is there. So pre-treatment with OCP definitely helps in
if you
subsequent
are using adjuvant like metformin and inositol, when her HbA1c is normal, that means you are using it as an adjuvant for her ovulation. Fine. So, don't you think that hyper LH PCOS or any PCOS who is ovulating, not conceiving, should be given 1 or 2 cycle of OC pill?
Definitely, ma'am.
Yeah, it should be given, ma'am. It helps in reducing the androgen level
Who are
and
the
LH
ideal
level.
candidates for that?
Ideal candidates are those having features of hyperandrogenemia. So they are the ideal candidates, or obese ones. They also have high androgen level. We need to pre-treat it.
Obese PCOS now. Lean PCOS are more suitable for OCP as a pre-treatment. And metformin and inositol group would suit better to obese PCOS.
Yes.
Fine. IUI per se is not the treatment of choice for PCOS, but these ovulatory PCOS, even after this, if they are not conceiving, IUI can be thought about. Even adjuvants you can try. And what about only role of the luteal phase support only? That this patient is
Ma'am, luteal phase support.
ovulatory at
It is
present. And let me tell you, she has told me that she has done everything regarding lifestyle and she is still following that. So her BMI earlier was 28, 29. Now she has become 24 and she's ovulatory. And because of persistent anovulation, maybe earlier, her luteal phase is not very good. So, will any of you use only good luteal phase support for these
I do it.
patients?
I see the ovulation. I
Dydrogesterone.
start with dydrogesterone
Dydrogesterone, ma'am.
for 14
And
days.
luteal
I
phase defect is common in PCOS patient. Exact reason is not known, but maybe
Yes.
increased AMH or hyperinsulinemia, whatever the pathophysiology is, it is there. A
But the
luteal phase defect is
endometrium,
found
yes, ma'am.
commonly in
Endometrium
PCOS
are
patients.
always not very beautiful in PCOS patients. We need to look for the endometrial vascularity and endometrial lining. They are not that beautiful as compared to normal ovulatory patients.
Okay. So, Yukti, what is the basic defect in luteal phase in PCOS patients?
So, ma'am, in especially in anovulatory PCOS, there is a luteal phase defect. We see a low level, because of anovulation, there can be low level of progesterone, which will affect the endometrium and the receptivity. So, in those cases, anovulatory PCOS, definitely there is a role of luteal phase support.
There is
Ma'am, in PCOS, exactly the LH is tonically elevated and pulsatility
Yes.
of that progesterone is less.
Lost.
And that makes the corpus luteum dysfunctional. And this is the defect this causes a luteal phase defect in PCO patients. And so they need to be supported.
Yeah. So, though literature says that your ovulation induction cycles with oral ovulogins, if you are not doing IUI with gonadotropin or mix, do not require luteal phase support. But patients like polycystic ovarian syndrome, endometriosis, these are the cases where if you do luteal phase support, it helps them get pregnant. If you didn't do anything, you could have we can try 2 or 3 cycles and good luteal phase support and she might get pregnant, and that's exactly what happened. After 2 COCs, I was doing her natural cycle follicular monitoring. I kept her on dydrogesterone post rupture and she conceived immediately. Yeah. So now all IVF specialist enthusiasts, my last case, she is Mrs. Gupta, unknown case of PCOS, underwent COH for ICSI, antagonist protocol. E2 on the day of trigger was 3500 picogram per ml. She received 1 milligram of leuprolin as trigger. OPU done after 36 hours, no eggs received likha hai, retrieved from one side of the ovary. What next? Lot of trigger talks have been going by Dr. Ashish, and Rajesh has just thrown such a beautiful light on trigger and everything. So, what will be your next response?
First of all, as sir said, we can repeat the trigger with some other trigger and do the
So
pickup
first
after
of all,
30.
will you stop your retrieval process?
If after retrieving the eggs from one ovary we didn't get anything, we will test the follicular fluid for we have to test the follicular fluid for LH and LH SCG, and if it is low, we have to re-trigger her. And
She has just received leuprolin,
1 mg.
so SCG is not going to be there. Fine. So your UPT will not work. Your
LH levels, we have to do blood LH levels, serum LH levels.
And how much it should be if you expect that you should have got follicle?
15, more than 15. 15.
Okay. So what would have gone wrong in this case?
Less dose of leuprolin. We
Yeah.
generally give 2 milli. Yes, ma'am. 2 milligrams of leuprolin as a trigger.
Okay. So those could
I
have
prefer 3
lesser.
milligram of leuprolin as trigger.
Yes, 3 milligrams.
Yes.
So
We
yeah,
give
just
rather 2 decapeptyl.
one ampule of decapeptyl or leuprolin is having 0.5 milligram, isn't it?
Yes, ma'am.
So 1 milligram makes it 2.
Yes, ma'am.
So you give 3 ampule or 3 milligram as a
2 ampule of decapeptyl, ma'am.
Okay. And leuprolin?
Ma'am, 3
don't
mg of
I don't
leuprolin.
I've never gone beyond 3 ampule. So that makes it, I think, 1.5 milligram. So first of all, you will stop the procedure. Then you will test for the LH. It comes below 10. Then what will you do?
Retrigger.
Retrigger. And this time your choice would be?
SCG, ma'am.
SCG.
And how many hours do you take after the
24 hours.
Okay. Book says 36 hours.
Ma'am,
And
can we use a decapeptyl trigger here? Since we have a high estrogen level, can we use decapeptyl this time?
So what will be the difference between leuprolin and it is a rescue trigger? So what is the difference? Both are agonist trigger, and it is clearly showing that agonist trigger is not working. So any ideal trigger should have optimal oocyte retrieval. There should be no chance of empty follicle syndrome or OHSS. When you are giving, just let me ask you this way, if you are giving an agonist trigger, what all do you look at on the day of trigger, or you are deciding your trigger, what are the things you are looking at?
Especially number of mature follicles. If it is more than 10 in each ovary, then we are dropping SCG.
Size of the follicles.
The agonist.
Size and
Size E2 level.
Size of the
Don't do E2 level nowadays, ma'am.
estradiol level.
And anything else?
Vascularity of the follicle.
So let me tell you that whenever we are deciding about agonist trigger, even in hyperresponder, minimal LH activity should be there. If your LH level is less than 1.1 milligram international unit per ml, you are not going to get any follicle until unless you introduce a minimal amount of SCG. So agonist trigger cannot be given blindly on the basis of number of follicles and your E2 level. Fine. Then you will be getting empty follicles. Fine. So here you will have to add SCG ranging from 1000 to 5000, whatever, as per your E2 and number of follicles. And patients who have been kept on prolonged suppression like our donors. This is last question. So that will also, and this is the chances of getting, if you have given SCG trigger, 160 unit at least should be there at around 24 hours after SCG trigger, LH 50, 12 hours after GnRHA, and 10 after kisspeptin. I just wanted you to know. And this is the rescue protocol where you have to add SCG. You cannot repeat your rescue trigger with agonist again. And you always have to take whenever LH is low, less than 0.1 or 0.5, you have to add SCG. Otherwise, you will not get. When you are doing TIC, IOI, you have to look at the size of the follicle. These are for people who are not practicing IVF, but they require trigger everything. CC around 22 or more, gonadotropin 16 to 18. And these are the various cycles. How do you trigger your patient? Yeah. I couldn't hear Vessi, so I stopped it abruptly because I thought I am overshooting.
It
Thank
was
you, dear
great.
panelists.
Thank you, ma'am. Thank you so much. Thank
Seema
you.
ma'am,
Huh?
would you
Thank you,
like to
ma'am.
have dual trigger in normoresponder patients?
I always use only dual trigger and Agnes trigger. I never use SCG trigger alone.
And what's the time of pickup exact?
34 hours is my usual time.
And the same time you are giving the both the agonist and HCG?
Yeah, together.
Fine. And 2 decapeptyl and 10.
I don't use decapeptyl. I use leuprolin more.
Leuprolin 2 grams.
I use 2 ampules, one on each thigh, along with 1000 to 2000 of SCG urinary. And if I am giving it to normal responders, then 1 Ovitril and 1 ampule leuprolin. Thank you, my dear panelists.
Thank
You all
ma'am.
were awesome. Since it was very late, I was just running my presentation so that people they don't get bored.
I think thank you, Dr. Seema, for covering that very, very interesting cases because your experience, somebody has on two devices. Sorry, your experience is enlightened with the echo is coming, somebody is on the two device.
Someone has joined from 2 devices.
Yes, yes.
Yeah, now, yeah.
Thank you, Anu ma'am, for the opportunity, and thank you,
Thank you, Anu ma'am.
Thank you so much.
You're
Thank you.
most welcome. You all were amazing. And Dr. Seema, you did a wonderful job. मतलब हम लोग इतनी रात में बिल्कुल ऐसे बैठे हैं सुन रहे हैं. Wow, कितना interesting है.
मेरा
Thank
वीडियो
you.
ऑन नहीं हो रहा है. थैंक यू अनु, तुमने मुझे ultimately I was able to. I was planning to come to this webinar for last 3-4 months since its inception, but I wasn't able to. I feel so good. Thank you, Fessy. Thank you, Anu. Thank you, dear panelists and all the viewers.
Ma'am, can I give a vote of thanks?
Thank you, Anas.
Yes, of course.
So on behalf of UNS, Dr. Manish Garg as well as Nakul Patel would like to offer our sincere thanks to Dr. Amit Patki sir, who is the ISAR president, for helping us organize this along with the conveners, Dr. Anu Agarwal ma'am and Dr. Fessy Lewis sir. So a sincere thanks to Dr. Amit Patki sir. Also sincere thanks to Madam Asha Bakshi madam. For helping us conduct this meeting. Also, a big thanks to Dr. Prakash Trivedi, sir, who has been the chief guest for this session, the 5th in the series of Catalyst webinar. Guest of honor, Dr. Kanti Bansal, ma'am. And a sincere thanks to all the speakers, all the chairpersons, all the moderators, and the panelists who have graced this occasion and help us conduct this beautifully. We had, in fact, more than 450 participants who had logged in. So, a sincere thanks to all the participants and audience who have logged into this session. This program would be available online also subsequently in few days on the ISAR website. So, please pass on the message to your colleagues in case someone has missed out attending this session. So, again, on behalf of UNS and the entire team at UNS, we thank ISAR as well as Anu Agarwal ma'am and Fessy Lewis for helping with this meeting. Thanks a lot. Have a nice evening and good night from our end. Thanks a lot.
I think thank you all for this joining in. And usually we were started as first Tuesday, and because of Diwali and this time also because it was very near, we are changing into second Tuesday. Next month also, most probably we will be doing the second Tuesday only because of ACOG starting on 8th. So I think we will update you soon. Thanks UNS and thanks all the faculty. Thanks Amit Patki, President and Secretary, Dr. Asha Bakshi and today's chief guest and guest of honor, and Dr. Rajesh and Dr. Ashish and Dr. Seema for that wonderful deliberation, and all the panel members and all the chairpersons for staying until the end. Thank you. Over to Dr. Anu.
Thank you. Thank you to all. It was a wonderful session.
Thank you, Dr. Anu. Thank you, Dr. Vessi. Good night.
And I hope I didn't miss
Thank
out
you.
on any
Thank you, Dr.
panelists,
Seema.
any one of you. Because
Yeah.
I was just keeping it here कि किसी को छोड़ ना दो, किसी से क्वेश्चन पूछना भूल ना जाओ क्योंकि वो दिख नहीं रहे थे विंडो में सब लोग.
नहीं, आपने सबसे पूछा.
ठीक है.
Missing your Banaras trip again.
Okay.
मैम की बनारस ट्रिप दोबारा से होनी चाहिए अब.
बनारस ट्रिप?
RX event, can you stop
मैम
the meeting?
जेनेटिक्स के ऊपर फिर से वो
कॉन्फ्रेंस.
यस मैम.